particular in the respective body area. It is mostly a synovial joint, and very important synovial joints is the upper limb and the lower limbs, even your hands. Now, synovial joint, most mobile type of joint. Articular surface covered with hyaline cartilage. This is the hyaline cartilage. This is the bone. Joint surrounded by fibrous capsule lined by synovial membrane. Between articular surface is joint cavity filled with synovial fluid. The simple thing is that two bony surface. Now it has to glide and move freely. So you have to have some lubricant. And lubricant here, it is the synovial fluid. Okay? And now two bony bones, the femur and the tibia. They cannot be standing on loose, but you will see it is being surrounded by the capsule. When you open the shoulder joint, you will be seeing the capsule of the joint. Okay? Now, most evolved and mobile type of joint. Characteristics. Here you see the picture. This is the periosteum of the bone. Now, this is the ligaments. This part, the joint cavity. And the hyaline cartilage articular surface is lined by the hyaline cartilage. And this is the fibrous capsule. And this is the synovial membrane. The green is the synovial membrane. And the articular capsule is here. Articular cartilage, cavity filled with synovial fluid, articular capsule outer fibrous inner synovial membrane. So, the synovial membrane, when you open in the dead body, you will see, but the external, the capsule, the ligaments and muscles and whatever it is giving a total, it surrounds the bone. Okay? Now, ligamental support. Now, every ligament over there is vital. Like you will be reading that some player একটা ligament injury হয়েছে, meniscal tear হয়েছে. So, it has to go either depending on the grievous injury. So, things are planned accordingly. If it is a minor injury, then you just rest and plaster or bandage. There are beautiful splints in the market. Now, you need not plaster the whole thing from here to here, but there are numerous splints you will be encountering when you do your orthopedics. There are splints, and you see. আসুন আসুন বেশ শোনো দেরি হলে ঢুকে যাবে হ্যাঁ একবারে straight take your seat. Articular disc or menisci. Now this is the part. Now this is the femur and this is the tibia. Now you see the anterior cruciate ligament and the posterior cruciate ligament. I will show you a beautiful picture slide. This is a cross section taken in this section. Then you will see the ligament there. I'll show you in, one slide there. and see with the lower end of femur, the tendon of quadriceps, suprapatellar bursa. This is suprapatellar bursa. This is a patella, and this is subserous prepatellar bursa, and the synovial cavity, lateral meniscus. The lateral meniscus is here, it is shown cut, and the articular capsule and tibia. This is a very common question of knee joint. Around 10 marks, describe, show a diagram, draw a diagram, and label it. And of course the functions. So you can draw, you will see that 2 or 3 diagrams you draw, and depending on how much marks you are going to be, if it's 10 marks, then try to draw 3 pictures in different views. If you have a shortage of time, then you draw 2 pictures. Now, articular cartilage, in most of the joint is hyaline cartilage except in some fibrocartilage. So most of the joints, the synovial joint is the hyaline cartilage, but in some there is fibrocartilage. This picture I was telling you that, see the ligament, and this is the menisci, this is the lower end of the femur, this is the capsule, and this is the lower end of tibia, this is the upper end of tibia. These are the cruciate ligaments. Now, you see the hyaline cartilage and reduces friction, acts as a shock absorber. The other day I told you regarding how the shock absorber, it acts, and the lubricant is the synovial fluid. Now, where resistant and low friction and lubricated, the idea of, say, in any machine, at the end of the day, we are having our limbs and we are using, it is a machine, we are a machine. So, it has to be lubricated. So, in any pathological condition or any traumatic condition, the lubricant, the synovial fluid, if it might be, there will be excess secretion or there will be poor secretion, and that leads to the presentation of the case, how that diseased person or a traumatic person presents to you. And accordingly, if there's a huge swelling of synovial fluid, then I told you that you have to first tap, or you syringe it out, how much you can, give antibiotics, rest, and put a cast. Cast means is modern, this thing, splints, I would rather say. And previously we used to plaster. That is a plaster of Paris. That comes in the 60s, earlier days, and in your 70s, late 70s, it was the ordinary bandage and plaster of Paris powder you used to just put in folds and then make it. But nowadays you get it ready. There are some companies, Gypsona and other companies, that is ready in 2 inches, 3 inches, 6 inches, the diameter of the bandage. And that is impregnated with the plaster of Paris. And that gives you just put it in lukewarm water, but you see, you hold the bandage like this, put it there, and then you make. And if it is a cast you want to make, that you would wrap, you can just put it, but you have to, the end you have to, just wait for 1 minute. Let the bubbles come out, that means that whole bandage is soaked. So, the next phase is that, now you want to do a cast. Then you see, I want to give nowadays you get the splints, but I'm saying in some condition you need a plaster of Paris cast. So you measure from the one end to the other end how much you want to support, and according to the injury, it is that you have to measure, put this, and you fold, and you see. Now you have to give say you want to, you don't have the facility, but you can give a support. So you give it like that. At the worst condition, if you are posted in, say, some forest or Darjeeling or anything, or the hills, then you take a piece of cardboard, or you tell the local people, they immediately will cut a bamboo and they make it in pieces, and then you can give, say, 2 inches. They will 2 or 3 support, put cotton and bandage it and give a support. The ultimate aim and goal is that you lessen the pain. Ekta haat erokom kore Darjeeling থেকে শিলিগুড়ি নামবে, so you can see the amount of pain she will be or he will be encountering. So you give the first aid, try to, say I am in Siliguri, an orthopedic surgeon. I cannot abuse you. I cannot say, oh, এসব পড়াশোনা করে না ছেলেরা, কি শিখেছে? এটা তোমরা জানো, এটা তোমার প্রাইডকে যেন তোমাকে ইয়ে না করে, এই সেন্সগুলো কিন্তু তোমার থাকতে হবে। Because see, one of my teachers, Professor Ghosh, he used to, in the evening rounds after the internship, 3 months internship in gynecology and obstetrics, he gave me so many tips and so many lessons. I still carry on. Even some modern degree holders in gynecology, they are missing. Just say, I'm just giving an example that he used to do 50 patients of speculum examination of the cervix to see a small polyp. But I see many doctors, they are prescribing hormones. But that polyp is the cause of bleeding. It is not the hormonal disturbance that is causing the bleeding. This is the content. So, and when you write your history, even in LMC, recently I saw in medical dialogues that your prescription should be clear. Whatever your findings should be clear. Eta kintu tumi habit kore felbe. Like get up, you yawn, and then to take a brush. একটু চোখের ঘুমের ঘোরেই ব্রাশ নিলে, টুথপেস্ট নিলে, এই যে হ্যাবিটটা হয়ে গেছে, similarly you do this. Now, where resistance. Now see, structure of synovial joint. This is the articular cartilage. This is the bone. This is the synovial membrane. This is the joint capsule. And this is the periosteum. This is the bone. Avascular, non-nervous, elastic in nature, and inherent slippery. Circumferential dimensions are opposite on approximate surfaces. It is indispensable. Young and old cartilage. Functions. Provides smooth gliding surface and reduces forces of compression on weight bearing. Now, this component function provides smooth gliding. দেখবে যে তুমি এরকম করে ধরে আছি নি জয়েন্টে, আস্তে 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 তুমি একটা কাউকে বললে যে এক্সারসাইজ, sit down on a chair and do quadriceps, you just contract the quadriceps muscles. And anyone who's complaining with knee joint pain, and slowly, you just ask her to move. তোমার একবারে 180 degree হলো না, but at least you tell her not to bear any load or weight bearing, but she has to keep on moving passively in the thing, on her seat or on her bed. যেমন তোমার একটা প্লাস্টার কাস্ট হলো, আমরা হাতে একটা কিছু ইনজুরি হলো, একটা ব্যান্ডেজ করলাম, সবসময় আমরা বলি যে একটু হাত নাড়াবেন, হাত নাড়াবেন, হাত নাড়াবেন। Because see, this is the example of this hand. Now, there are numerous small joints and cartilage. And interesting thing is that why now these are the joint spaces. This is the joint. The cartilage is there, and you see now the vessel this will supply one single vessel, and see this is the nerve. Okay, now you see the web space. See, this is I'm saying just drawing. Okay, this is the web space of the head. Web space. So, if there's a small cut injury, you just block and with the xylocaine, and then you address to the trauma. And see, these are the একটা hand injury যখন নিয়ে আসবে না, be very gentle, be very delicate, because তোমার একটা ভুলের জন্য, if you make this thing, that blood supply, that joint space, everything goes jeopardized. Now, this is to be looked into, and now regulation of growth of epiphysis, structure and changes, chondrocytes and collagen fibers from territorial and interterritorial arranged in 3 layers. Now, these are the zones, the calcified cartilage and subchondral bone. Now, degenerative and proliferative changes occurs in cartilage in the advanced stage. Now, how much degeneration is going on? How much this thing? Now, very good digital X-rays you can see, but you have to go if the trauma, I'm from large joints or some this thing you need to operate on, then you have to do an MRI or CT, because that gives lots of information, and see how much tissue handling you have to manage during operations. Now, these are the process. Now, this is the inflammatory cells, chemokinins, cartilage proteins are there, synovial fibroblasts and synovial fibrosis, degenerative proteins, PG synthesis, cartilage, this is the cartilage, this is the chondrocytes, and this is the osteoblast, bone marrow stromal cells. Nutrition. Articular capsule consists of outer fibrous and inner synovial membrane covering non-articular surface also. Now, this is an important point to note, that articular capsule, you get a 4 marks question. So you have to focus on consists of outer fibrous layer and inner synovial membrane covering non-articular surface also. যেখানে কোনো bones নেই সেখানে articular surface, you see the joint, knee joint, or I showed you the section. This is the part that you're going for honors, you're going for a gold medal paper, then you are answering very well. Then suddenly one of the examiners asks you that articular capsule consists of outer fibrous layer and inner synovial membrane covering non-articular surface also. Now this point is to be noted. The non-articular surface of synovial membrane থাকে. Just the bony surface does not have means only the bony surface is not covered by synovial membrane. But non-articular surfaces also is ধরো একটা বোনের তো আর্টিকুলার সার্ফেস আছে, নন আর্টিকুলার সার্ফেস আছে। এবার নি জয়েন্টের এখানে কি হচ্ছে, the parts, the upper end and the lower end of the tibia and the upper end of the tibia and the lower end of the femur is the bony component. But the lateral portion where the lateral ligament, medial ligament of the knee joint, this whole capsule, it is even lubricated because otherwise শুধু এরকম মুভমেন্ট হবে। কিন্তু এই যে একটু এরকম হয়ে গেলাম, একটু এরকম হয়ে গেলাম, এই চার্লি চ্যাপলিনের মতো হাঁটতে লাগলাম এরকম করে, তো একটা ফুটবল করলাম, তো দ্যাট মোবিলিটি that has a significance. So পুরোটাই তোমার covered with the bony component and non-bony component. Now this is the fibrous joint capsule and this is the synovial fluid, lubricates the joint, synovial membrane produces synovial fluid, and tendon joins muscles to bone enable movement. Now the tendons, the tendons are inserted in the respective bones, in the respective, the other bone which forms the joint. Now it has a covering the non-articular surface also. Now this is in superior extremity, this is the accruement process. This is the ligament. তোমাদের হিউমারাস হয়েছে, ক্যাপুলা হয়ে গেছে, ক্লাভিকেল হয়ে গেছে। Now complete investment with exception synovial protrusion. Now this is the head of the humerus. When you open the shoulder joint, when you open, then you can see it will be represented by this picture and muscle, the rotator cuff. Now the capsule shoulder joint opened, glenoidal cavity, this is the glenoidal cavity, and acromial process, cut. Now there is in the shoulder joint 10 marks or 5 marks or 8 marks. I'm not branding it or labeling it. But it's a very common question comes. Rotator cuff, describe the rotator cuff of the shoulder joint. Or তোমার ভাইভাতে তোমাকে জিজ্ঞেস করলো, হসপিতে জিজ্ঞেস করলো, rotator cuff, what are the muscle components of rotator cuff, or what 5টা পয়েন্ট 4টে পয়েন্ট যা থাকবে সেটা তুমি লিখবে। Now very vascular, nervous, and may have apertures. Capsular ligament, extra or intracapsular tendons. Now you see this is synovium, this is the tendon. It is acting like the pulley on resting on the bone. Now, if you see your own hand, you see the tendons. You can this structure is there. So, if a cut injury is there, তাহলে তুমি প্রথমেই আসছে, I told you that blood pressure cuff, you will act as a very good tourniquet. হ্যাঁ, তুমি রবার খুঁজে পাচ্ছ না, খুঁজে পাচ্ছ না, that is the best tourniquet. Now, you increase the pressure, the bleeding stops. Then slowly see how much and where it is bleeding from. And accordingly, you repair one thing and try to see the functions of the fingers, the function of the hand, which tendon is injured or not. If you are suspicious or if you are very sure of a tendon injury, please, with a highlighter pen, you give a note that the tendon is cut or there is abrasion injury. Please note and repair. Okay. You are transporting to some hand surgeon. But ওটা তো ড্রিম, ওগুলো তো আসতে এখনো 50 বছর 100 বছর। হ্যাঁ, কিন্তু যখন আছে তখন তুমি নিজে করবে। ও এটা তো অর্থোপেডিক্সের, ওটা তো এটা একটা ট্রেন্ড এসে গেছে। ধরো আমি প্রফেসর সার্জারি, রামপুরহাট মেডিকেল কলেজ, আমি গভর্নমেন্ট কলেজের কথা বলছি, আমি বলে দিচ্ছি যে এটা পিজি রেফার টু বর্ধমান মেডিকেল কলেজ। বাঙালিরা গত 30 বছর 40 বছর ধরে রেফারেল ডাক্তার হয়ে গেছিল। আমি কেন বলছি, এই রেফার করতে করতে কিন্তু তুমি আবার যদি পিজিতে থাকো, বর্ধমান মেডিকেল কলেজে হেডে থাকো, তা সেই হিপোক্রেসি, তখন কিন্তু তোমাকে মাঠে নামতে হচ্ছে। You understand what I'm saying? You're enough intelligent. Naturally, you please try your best and give your best as an MBBS. A good MBBS is a good postgraduate. Binding of bones, the articular capsule. We are discussing the articular capsule, the binding of the bones. I told you that you'll be seeing in your practical classes, and support to synovial membrane. At a membrane, naturally that has to be protected. Watchdog action. Now, synovial membrane. This is a picture of the healthy joint, the synovial membrane, the cartilage. This blue is synovial fluid, this is the bone. Okay? Now, highly vascular, non-nervous and cellular connective tissue membrane, which lines inside of the capsule, bone, tendon, intracapsular ligament, and bursa except cartilage and discs. Now, what is synovial membrane? Dhoro to menisci, the cartilage you're describing, it is covered by synovial membrane. It is the highly vascular and cellular connective tissue membrane which lines inside of the capsule, bone, tendon, intercapsular ligament, and bursa except cartilage and disc. It covers all these areas except the cartilage and the disc. Okay? Now again, this is the fibrous joint capsule. This is the tendon, this is the muscle belly. This is synovial membrane, this is synovial fluid. Now structure, pink, smooth and shiny cells of membrane are arranged in two zones, inner and outer. Now the structure is the pink, smooth and shiny. Cells of membrane are arranged in two zones, inner and outer. Functions: secretion of synovial fluid, liberation of hyaluronic acid and removal of particulate matters. Type: fibrous, areolar, adipose. Now, the synovial membrane type is fibrous, areolar, adipose. Synovial fluid. Now, this is the cross section of the shoulder joint. This is the acromion. This is the bursa. This is the clavicle. This is the coracoid process. This is your revision. Now, this is scapula. These are the cartilage and the joint capsule with fluid. This is the capsule and this is the inside the fluid. Synovial fluid, low volume, pale yellow viscous alkaline fluid, disilate of plasma which is added with hyaluronic acid. Hyaluronic acid is responsible for viscosity. Functions: nutrition, lubrication of cavity and wear and tear, elastic fluid film, weeping, lubrication and boostering effect of lubrication, and environmental temperature and viscosity, more movement and lubrication. Now, ligaments. Now you see this is the shoulder joint depicted in this picture. Now this is the acromion process, the coracoacromial ligament. So when the osteology away, you asked to hold the scapula to tolo. এবার এক্সটার্নাল সে একটু কাজু খাবে, একটু চা খাবে, একটু লেমন টি খাবে, এদিকে আমার সঙ্গে গল্প করবে, কিন্তু কানটা খোলা আছে। তুমি ভাবছো যে কথা বলছে একটু ভুলভাল বকে দিলে, সেটা করবে না। শুনুক না শুনুক, ও শুনছে না শুনছে তোমার বদরেশন নেই, তুমি বলে যাবে ঠিক বেঠিক, যেটাই বলবে স্মার্টলি বলবে। তার মানে 5টা ব্লান্ডার করে স্মার্টলি বলে দিলে সেটা ঠিক না, সেটা ঠিক না। ওকে, এক্সকিউজ মি। নাও coracohumeral, the coracoid process, this is the humerus. Now greater tubercle of the humerus. Now articular capsule reinforced by glenohumeral ligament. This is the subscapular bursa. This is the tendon sheath that is going. Tendon of long head of biceps brachii. Now, the tendon of the long head of bicipital group, you have seen the humerus. It goes and gets into the cubital fossa. So, this is the tendon sheath, tendon of the long head of biceps, and tendon of subscapularis. Scapula, articular capsule reinforced by glenohumeral ligament. This is the coracoid process. Now, tendon of subscapularis. It may be true or accessory. It may be intra or extracapsular, intra or extrasynovial. Now you can see the picture and ligaments. It may be true or accessory. It may be intra or extracapsular. এটা ইন্ট্রাক্যাপসুলে থাকতে পারে, এক্সট্রাক্যাপসুলে থাকতে পারে এবং ইন্ট্রা অর এক্সট্রা সাইনোভিয়াল। ঠিক আছে, তোমরা কথা বলো না, তোমাকে বলছি, তোমাদের বলছি, দেখো দেখো, তাকাও তাকাও, তাকালেও শোনো, চোখে চোখে কথা বলে, মুখে কিছু বলে না। গান একটা ছিল আরতি মুখার্জি, হ্যাঁ। Now may show phylogeny, functions, permit desirable movement, stability, articular discs, menisci, fat pads and labra. Now joint cavities sometimes divided by fibrocartilage disc into compartments due to low congruence. Division may be complete, jaw joint, sternoclavicular joint and inferior radioulnar joint, or incomplete, knee and acromioclavicular joint. Now you see the hand over here. This is the ulna, this is the radius, this is the articular disc between lunate, scaphoid, trapezoid, trapezium, hamate, tricrutal, capitate. These are the bones which you will enter. It's not now, but you will enter the upper limb when you go from the clavicle, you are moving down. Naturally, these bones, small bones, you will encounter. Need not panic. I can show you some pictures, even that you can see how to remember that, memorize them. Now, this is the temple bone, this is the temporal bone, condyle and disc. This is the when you read the mandible and the temporal bone. So, it is a actually আটকে যায়, লক জ হয়ে যায়। একজন গালাগাল দিচ্ছে দুঃশালা, সা বললো সঙ্গে সঙ্গে আটকে গেল। হ্যাঁ, তো সে কমপ্লিট করতে পারলো না, সাথেই আটকে গেল। Then you have to manage it. Nowadays, local under anesthesia, or there is some procedure. You have to take it and then pull it and slide it, glide to its place. Okay. Now, this was, see the femur, this is the tibia, this is the ligament. Functions: lubrication by maintenance of interval, gliding and angular movements, prevention of wear and tear of articular cartilage. Why articular cartilage differ from typical hyaline cartilage? Now, this is important. You can note it or take a ছবি তুলে নাও, আবার updated post profile দিয়ে দিও না। Okay. Now, see why articular cartilage differ from typical hyaline cartilage. Articular cartilage is devoid of perichondrium, more avascular, nutrition through synovial fluid, does not regenerate, this is important, does not undergo ossification with age. Criteria for classification: according to the number of articulating surfaces. Simple, only two bones come in articulate. Example, interphalangeal joint. Here, the hand. These are the phalanges. In between these are the metacarpal, metacarpal bones, these are the carpal bones. Compound: more than two articulating surfaces involved and share a common articular capsule. Example, elbow, ankle, radiocarpal joint. More than two articulating surface involved and share a common articular capsule. ধরো এলবোটা, এখানে তিনটে বোন আছে, lower end of humerus, upper end of radius and ulna. Now, it is covered by capsule. So, compound, this is a compound. And two bones. Now, here, you see this is the capitulum, this is the trochlea, this is the trochlear notch of the ulna, this is the head of the radius, and radial notch. Complex joint cavity divided into compartments by articular disc or menisci, knee and sternoclavicular joint. So simple, compound, complex. Simple, compound and complex. See this is the femur, this is the anterior cruciate ligament, this is the posterior cruciate ligament, and these are the two menisci. Menisci are semilunar shaped. When you will be doing your lower limb, you will see it. According to the axis of movement, uniaxial joint, it has 1 degree of freedom, example elbow, ankle and interphalangeal joint. এই ইন্টারফ্যালেঞ্জিয়াল জয়েন্টগুলোকে তুমি বাট একটু ঘোরাতে পারবে না। আর এদিকে দেখো অ্যাঙ্কেল জয়েন্টও তোমার কি হয়, তাই জন্য অ্যাঙ্কেল স্প্রেইন হয় বেশি। ইয়ার চট করে সিঁড়িতে নামতে গিয়ে ঘুরে গেল পাটা, কিন্তু সিমিলারলি তখন তোমার অ্যাঙ্কেলটা যখন ঘুরছে কিন্তু তোমার নি জয়েন্টটাও কিন্তু ভাঁজ হয়ে গেল, কিন্তু নি জয়েন্টের ইঞ্জুরিটা হচ্ছে না, তখন কিন্তু অ্যাঙ্কেল স্প্রেইন হয়ে গেল, একটা লিগামেন্ট ছেড়ে গেল, একটা ক্যাপসুলের পার্ট ছেড়ে গেল, ইট গেটস অ্যান্ড সি স্প্রেইন ইজ মোর পেইনফুল, হ্যাঁ সোলেন হয়ে যাবে। তো biaxial joint, it has 2 degrees of freedom, radiocarpal and metacarpophalangeal joint. And polyaxial joint possesses 3 degrees of freedom, morphologically called as ball and socket type of joint, example shoulder, hip, talocalcinonavicular joint. তো এটা তো তুমি মুভমেন্ট জানোই কতটা কি হচ্ছে, হ্যাঁ। polyaxial. Now, plane of synovial joint, articular surfaces are flat. This is the plane. Permit gliding movement. Example, intercarpal joints, intertarsal joints, joints between articular process of vertebra. এগুলো মুভমেন্টগুলো কিন্তু restricted, অনেকটা restricted. So, plane of synovial joint. You see the arrows, this is the arrows. This you can just like this, it's moving like this. You just do this. Okay. Now example, intercarpal joints, intertarsal joints, joint between articular processes of vertebra. Hinge joint. Now the articular surfaces are pulley shaped. Movement permitted in one plane around transverse axis. Example, elbow joint, ankle joint, knee joint, modified hinge joint, and interphalangeal joints. This is the articular surface of pulley-shaped hinge joint. Now, pivot joint. Articular surfaces comprises of central bony pivot and by medial atlantoaxial joint. Okay, and your superior radioulnar joint. You vicca nichi, vicca dichi, vicca nichi, vicca dichi, vicca nichi, vicca dichi. This is important because some injury is there or something like that, and you ask the person, put the elbow joint এরকম করে ফিক্স করে দিল, দিয়ে তাকে এক্সারসাইজ করাবে। ভিক্ষা নিচ্ছি, ভিক্ষা দিচ্ছি, ভিক্ষা নিচ্ছি, ভিক্ষা নিচ্ছি, ভিক্ষা দিচ্ছি, ভিক্ষা নিচ্ছি। ওকে, প্লাস এই ফিঙ্গারের মুভমেন্টগুলো, জপা, এনি রিলিজন, বিডস কাউন্টিং আছে, আবার আজকাল আবার কাউন্টার এসে গেছে, মানে কবার জব করছো, ওম শিবায় নমঃ, ওম শিবায় নমঃ, ওম শিবায় নমঃ, সেটা ওটা ডিজিটালি ক্লকের মতো টাইম করে দিলে তো সেটা হয়ে যাচ্ছে। অত ডিজিটাল না, হাতে হাতে গোনো, ভুলভাল হবে। তুমি হয়তো 90 বার গুনেছো, 105 বার গোনা হয়নি, তুমি 105 বার হিসেবে ধরবে, তাতে ক্ষতি নেই, ঠিক আছে? নাও condylar joint. Now condylar joint. The name condyles. Now ovoid articular surface condyle fits into an elliptical cavity. তুমি দেখো এই যে এটা আছে, তুমি যখন occipital bone পড়বে, and that আজকে দেখে নিও, if you have the histology class or some time you get, see the skeleton, দেখে নেবে এই জায়গাটা। আর permits movements in two planes, flexion, extension and rotation possible. Example, temporomandibular joint, atlanto-occipital joint and radiohumeral joint. Now, a short note, 4 marks. Condylar joint. একটা whole component of joints বলে একটা কোনো question আসবে না, because it's a big component. So it might be in fragments. It might be just synovial joint, or what is synovial membrane, or what is synovial fluid. So accordingly, you have to make up your notes. Okay, by the way, you can look into Vishram Singh's 2 books he has come out with. That is your selective anatomy. Selective anatomy, এতে খুব শোনো, কিছু সবই ইম্পর্টেন্ট, কিছু ইম্পর্টেন্ট নয়। তো এগুলো বেরিয়েছে, তোমরা দেখতে পারো। আর একজন আছে কাজী বলে, সে বিশ্বম সিং এর আগে, এটা ইয়াং গাই ফ্রম লখনউ। এর ফরওয়ার্ডটা লিখেছে Mehdi Hasan, Professor Mehdi Hasan, DSc, is a big shot, he's a big guy, and it happened that first MBBS Mehdi Hasan কে কাছে আমরাই দিয়েছি পরীক্ষা, আমাদের ব্যাচ বর্ধমানে। ইজ অ্যান এক্সটার্নাল এক্সামিনার। ও তখন বেলবটস প্যান্ট আর a hero, and he's always a hero. And by his name, Mehdi Hasan Gold Medal Award, I got it in the Anatomical Society for best clinical paper in appendicectomy. আমি একটা ইনসিশন লাইন, এটা দেখা যায় না পেটে, সেটা not laparoscope, but it's a conventional operation. Now, see the condylar joint, you can see the temporomandibular joint, atlanto-occipital joint, radiohumeral joint. আজকে বা পরপর যাদের হবে, স্কেলেটনটা দেখে নেবে, এই পেছনটা দেখে নেবে, কবে হেড নেক হবে সে কামিং ইয়ারে। সো ডোন্ট ওয়েট, আজকে কম্পাউন্ডটা হচ্ছে দেখে নিলে যে হ্যাঁ এরকম হতো, এটা রেডিও সুপিরিয়র এক্সট্রিমিটি হচ্ছে, তোমার atlanto-occipital, radiohumeral joint, এগুলো সব দেখে নেবে। Now, ellipsoid joint, convex articular surface fits into concave cavity. It's a concave cavity and a convex articular surface. Now, permit movement in 2 planes, flexion, extension and adduction possible. Metacarpophalange, তুমি নিজের মুভমেন্টটা দেখো না, এই। So, what is this? This is the ellipsoid joint. All these joints are ellipsoid. That means a convex and a concave surface. এবার কি বলছি, তোমরা একটা আর্টিকুলেটেড হ্যান্ড তোমরা দেখবে, যখন তোমাদের টাইম আসবে দেখে নেবে, বা এখন তোমরা সুরেশকে বলবে যে আর্টিকুলেটেড হ্যান্ড একটা দেখাও। আর রেডিয়াস আল্লাটা তুমি দেখতে পাবে মানে স্কেলেটনে, স্কেলেটন বলতে আর্টিকুলেটেড স্কেলেটন। ওকে, নাও Saddle joint. Now, articular surfaces are reciprocally concave to convex, this part. Movement possible in multiple axes. Flexion, extension, adduction, abduction, and rotation is permitted. This is Buddha. For example, first carpometacarpal joint, sternoclavicular joint, and calcaneocuboidal joint. Calcaneum with cuboid. And sternoclavicular joint. The first carpometacarpal joint. Ball and socket joint. Articular surfaces include a globular head fitting into a cup-shaped socket. Here, the ball and socket joint here. Movements permitted in multiple axes. Flexion, extension, abduction, adduction, rotation, and circumduction is possible. Circumduction, adduction, abduction. আমি অতটা নাচতে পারি না, কিন্তু নিশ্চয়ই নাচতাম, নাচতে ভালোবাসি। তো এবার types of movement: gliding or translation. In plane joint, one bone glides over another bone with a limitation. Angular movement: flexion, extension, bending, straightening, or approximation and deviation of two morphological ventral surfaces. This principle has exceptions. Now, what are the exceptions? Abduction, adduction. The approximation or deviation of a part towards median plane or midline. Course of reference axis may be different. Circumduction. Combination of four angular movements, successive order describing a cone. Movement and mechanism: rotation. This movement occurs around a ventricle or longitudinal axis. This is the rotation proper. Rotation proper is of two types: adjunct and conjunct. Adjunct is due to muscles and conjunct due to configuration of articular surfaces. Additional rotations around transverse and anterior-posterior axis produce flexion, extension, abduction, adduction respectively. Movements and mechanism: factors limiting range of movement. Now, shape of articulating bones, tension of ligaments, tension of antagonistic muscles, approximation of soft parts, factors maintaining stability of joint, bony configuration, ligaments and muscles. Now, as you go through your osteology and seeing the dried bones, please try to correlate of the respective area what is being dissected. Then it will be clear to you. আমি তার জন্যই বলছি যে ভিড়ের মতো এমনি করে দেখছো বা ইয়ে করলো, দেখা হয়ে গেল, বাড়িতে ব্যাগ নিয়ে যেও না। Please sit tight up to 4, and if there is no classes from 4:30 to 5:30, there are some classes in the evening. So you sit tight for 2 hours or 1.5 hours with your book, with the dead body, with the skeleton. তাহলে তোমার অ্যানাটমিটা অনেকটাই স্মুথ হয়ে যাবে। কারণ দেখো, তোমরা একটা ক্রাউডের মধ্যে পড়ছো। আমরা পড়েছি 50 জন ছাত্র, 50, 2 বছর অ্যানাটমি পড়েছি, কিন্তু হিউমারাস তো পাল্টায়নি, স্ক্যাপুলাও পাল্টায়নি, প্রশ্নও পাল্টায়নি। ওটা 8 মাসের মধ্যে আসছে। আমি ভয় পাওয়াচ্ছি না, আমি কিন্তু তুমি যদি ঠিক এইভাবে মানে ঠিক কোরিলেট করে তুমি একটা হ্যাবিটের মধ্যে চলে আসো না, তোমার হোল মেডিকেল ক্যারিয়ারটা ঠিক সেইভাবে হবে। Bursa, a bursa, plural bursae, Latin bursa means synovialis, is a small fluid-filled sac lined by synovial membrane with an inner capillary layer of slimy fluid similar to that of an egg white. এটা এগ হোয়াইট হিসেবে আসছে। আবার আজকাল সব বাচ্চাদের মানে অনলাইনে নিয়ে আসছে, আমার নাতনির জন্য নাতনি অর্ডার করছে, তাতে স্লাইমি। So it is just even mold or this thing, plasticine, so a slime. Now this is, now egg white is the example. Now this is subdeltoid bursa. You can see the suprapatellar bursa. This is the cartilage and infrapatellar bursa. Prepatellar bursa. কি হয় এক এক সময় ক্রনিক একটা বসার ইয়েতেই হোক বা ইয়েতে দেখবে একজন চলে এলো এরকম একটা ফুলও নেই, অনেক সময় সেটা ইনফ্লেমড হয়ে যায়, দিয়ে ব্যথা, তখন তোমাকে তাকে অ্যাসিওর করতে হবে না এক্ষুনি অপারেশন চলবে না, তোমাকে রেস্টে থাকতে হবে, তোমাকে একটু অ্যানালজেসিক খেতে হবে, ওষুধপত্র খেতে হবে। আর তুমি কি কাজ করো? বললো আমি তো হাঁটু গেড়ে বসে আমি একটা কিছু করি আর কি, যাই উদ্দেশ্যটা কি, যে কোনো কাজই হতে পারে। তো সেই সময় অনেকের হয়, সবারই হয় না। ধরো 100টা একটা ফ্যাক্টরিতে কাজ করছে ধরো, বা 100 জন মুদিখানায় কাজ করছে, মুদি তার বিভিন্ন 100 জনের মধ্যে, তাদের মধ্যে দেখা যাবে যে 5-6 জন এইখানেও একটা সোয়েলিং হয়ে গেল। Don't be tempted to cut it, go for a surgery until it is necessary. It might be small, এটা ফুলে আছে, দেখতে খারাপ লাগছে, হঠাৎ করে একটু পেইন শুরু হয়েছে, just wait and watch and see. A surgeon is a surgeon when he knows not to cut. Right? ইলিয়াক ফসাতে পেইন হলো মানে কেটে দিলে, একটা বার্সাকে দেখলে সঙ্গে সঙ্গে বললো অ্যাবসেস, কেটে দিলে, ইনসিশন দিয়ে দিলে, নো 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 নো। আর সার্জন ইজ আ সার্জন ওয়েন হি নোজ নট টু কাট। এটা similarly you see here this aspirate. Now if you have suspicious, you are suspicious, or you are in a dilemma, or you cannot diagnose, you cannot think, at the mid of night একজন ইঞ্জুরি নিয়ে এলো পেটে, দেখলে যে পেট ফুলে ইয়ে হয়ে গেছে, ইউ ডোন্ট নো এক্স্যাক্টলি, সঙ্গে সঙ্গে তো কিন্তু তুমি তাকে রিসাসিটেট করবে। তুমি রিসাসিটেশন মিনস ইউ ফ্লুইডস, তারপরে যদি তার চটচট করে তুমি ব্লাড টেনে নিলে, ব্লাড গ্রুপ করিয়ে দিলে, সঙ্গে সঙ্গে দরকার হলে ব্লাড দেবে। এবার তুমি একটা ছোট্ট বড় মোটা নিডল দিয়ে, হোয়াইট বোর্ড, একটা সিরিঞ্জ 5 ml or 10 ml সিরিঞ্জ দিয়ে ঢুকিয়ে দিয়ে you pull, I mean you aspirate, then you might see red color. তখন you think then এটা grievous, একটা liver injury হতে পারে, kidney injury হতে পারে। So you, according to that, you manage the patient. So you have to know your anatomy and see the aspiration, inflamed subacromial bursa, now principles of general anatomy, convex surface, এগুলো তোমরা একটু পড়ে নিও। Geometric configuration, mechanical access of bone, movement executed by bone and permitted at joints are necessary for cancellology. Study of joints is known as cancellology. Oh, now I would request you to blood supply, epiphyseal vessels enter the long bones or near attachment of fibrous capsule and gives articular branches which ultimately break up into rich capillary plexus, synovial membrane. This periarterial plexus is known as circulus vasculosus. Atriovenous acidosis may exist. Nerve supply of joints, articular capsule and ligament process rich nerve supply, it contains sensory and autonomic fibers. Now sensation conveyed on proprioceptive reflex, এটা physiology-তেও পাবে তোমরা, Hilton's law, Gardner's applied anatomy dislocation, subluxation, sprain, arthritis, which have been, I have this rheumatic fever, rheumatoid arthritis, osteoarthritis, সব ডিসকাস করে নিয়েছি, সেপ্টিক আর্থ্রাইটিস, ফ্র্যাকচার অফ জয়েন্টস, স্টিফনেস, নিউরোপ্যাথিক।
The temperature graph is bell shaped. It increases with the increase in temperature initially, then reaches maximum at body temperature, that is optimum temperature, and then it falls rapidly with increasing further temperature of the medium. Correct? যার জন্য কি হয়, যখন আমাদের জ্বর হয়, fever, when we run high fever, that time we cannot digest food, so we are given easily digestible food. Correct? Why? Because at higher temperature enzyme loses its most of the catalytic property. Correct? pH. Draw this graph. Now every protein is unique by its components. It is made up of different amino acid. So depending on different amino. Now you have studied PI. Have you studied PI? What is PI? Good. So it's a property of amino acid. Do you agree? Good. So amino acids show no net charge at PI. Now the PI is usually arithmetic mean of K1 and K2. That is dissociation constant of amino group and carboxyl group. Right? Now if a protein is made up of several acidic amino acid, then the PI of the protein will be acidic. If the protein is made up of several alkaline amino acid, basic amino acid, then the PI of protein will be basic. Correct? Similarly, every protein will have a specific optimum pH for its highest activity. Now, what does it depend on? What is the basis? Basis is composition. Which amino acid is located at the substrate binding site or catalytic site? Right? The catalytic site, if the amino acid located, it has pH, low pH, low PI, then it will be around here. So for example, glutamic acid, aspartic acid. If they have higher pH like lysine, arginine, then they will move towards higher pH. Basically, their charge will change with pH of the medium. If the pH decreases, they are more prone to be found as cationic. If the pH increases, they are more prone to be found as anionic. Clear? So different protein, different enzymes have different pH or optimum pH. Optimum pH depends. pH maintains the ionic status of the amino acid residues present at the catalytic site. pH maintains the ionic status of the catalytic residues present in the amino acids present in the catalytic site. Sorry. Right. So pepsin has pH between 2 and 3. Salivary amylase has pH between 6 and 7. Salivary amylase. And alkaline phosphatase has pH between 9 and 10. Around 11, 10, 10.8, 11, like that. Acid phosphatase has pH between 4 and 6. Is not given here. So if I ask you what different enzymes, examples of different optimum pH, you should be able to answer. Okay. Now we come to the most important one, the substrate concentration. Substrate concentration. Now, if the substrate concentration increases, the rate of reaction increases. Okay. Then it reaches a standstill, the rate. Why? Because enzyme is limiting factor. The enzyme concentration is fixed. So when it reaches this state that all enzymes are occupied by substrate, then the rate of reaction will not increase further on further increase in substrate concentration. যখন এনজাইমের সংখ্যার সঙ্গে সাবস্ট্রেটের সংখ্যা সমান সমান হয়ে যাবে, তখন সাবস্ট্রেটের কনসেন্ট্রেশন আর বাড়ালেও সেটা আর বাড়বে না, তখন সেটা একটা স্ট্রেট লাইন হয়ে যাবে, এই স্ট্রেট লাইনের সঙ্গে ম্যাচ করবে। এই যে গ্রাফটা তৈরি হচ্ছে, কার্ভড গ্রাফ, হ্যাঁ, এই গ্রাফটা আমরা দেখব দিস উইল চেঞ্জ উইথ ডিফারেন্ট টাইপস অফ রিয়াকশন, হ্যাঁ, উইথ ডিফারেন্ট টাইপস অফ রিয়াকশন। তাহলে usually আমি কি বলবো, সাবস্ট্রেট কনসেন্ট্রেশন and rate of reaction will initially increase, then it will reach a maximum and then it will maintain parallel with the x-axis. Clear? Because enzyme concentration is a limiting factor. Fixed, ওটাকে বাড়ানো হচ্ছে না, ওটা একই থাকছে। হলো, এইটা নিয়ে অনেকগুলো কাজ করার পরে একটা ইকুয়েশন তৈরি করা হলো। এই ইকুয়েশনটা ডিটেলসে পরে আসবো। এই ইকুয়েশন লেখো, তাকে কোনটা কি বলে সেটা বোঝো। Michaelis Menten equation, V0 is equal to Vmax into substrate concentration by Km plus substrate concentration. V0 হচ্ছে initial velocity, correct? Vmax হচ্ছে maximum velocity, S মানে হচ্ছে substrate concentration, আর Km কে বলা হয় from the name of the inventor or discoverer, Michaelis constant. আচ্ছা, দেখো, enzyme reacts with substrate to form enzyme substrate complex with a constant reaction constant K1, and then it is converted to enzyme plus free enzyme plus product, that is called K2, and the backward reaction constant is K minus 1. Clear? Now initially they said that the velocity means what? Formation of DSDT, formation of DSDT. Now, because Michaelis and Menten, they both were chemists by nature. They were chemists by nature. So they issued some assumptions. What is assumption? They said what is that? The backward reaction is much bigger compared to forward reaction. That means their assumption was hardly any product is to be formed. But no product is formed. That was their assumptions. Whose assumptions? Michaelis and Menten. So they omitted this reaction. So V became DSDT. Correct? This is what? Correct? Constant. They named the constant as Ks. Who named? Michaelis and Menten assumed that in a reaction where enzyme is forming enzyme substrate complex and it is not forming any product, in that case the reaction constant is Ks. Almost 50 years after this discovery, Briggs and Holden. Among them, Holden you must have heard about, JBS Holden, যার নামে কলকাতায় একটা রাস্তাও আছে। He stayed here for some time. He was quite eligible for getting Nobel Prize, but he didn't get due to some other reasons. God knows. Anyway, JBS Holden and Briggs, they named it differently. They said, in biological system, in chemistry, it might be, but in biological system, correct? That means what? Product is being formed. Product is being formed, so it has to be taken into consideration. Correct? So they added one extra K2 and named it after Michaelis as Km. So Michaelis did not name it as Km. It was Briggs and Holden, 50 years after the discovery of this equation, they named it as Km. So what is the Briggs-Holden modification? সিম্পল ব্যাপারটা, এই ছবিটা আঁকতে হবে, ইকুয়েশনটা লিখতে হবে, এটা হচ্ছে Briggs-Holden modification. K minus 1 is not at all, or K2 is not negligible. Clear? Briggs-Holden modification. Michaelis-Menten ইকুয়েশন বললে আমরা কিন্তু ওই ইকুয়েশনে লিখব উইথ Km. কিন্তু Kmটা মাইকেলিস নামকরণ করেনি, Kmটাকে নামকরণ করেছিল ব্রিগস অ্যান্ড জেবিএস হলডেন। ঠিক আছে, বোঝা গেল এই পর্যন্ত? ক্লিয়ার? এবার দেখো, উইথ gradual increase in substrate concentration, like this a graph is formed. এই গ্রাফটা এখানে ছবি আঁকতে দেখতে সুন্দর লাগে বলে এরকম ভাবে বানানো হয়েছে, কিন্তু অ্যাকচুয়ালি যখন আমরা গ্রাফটা বানাবো, গ্রাফটা এরকম দেখতে হয়, পয়েন্টগুলো হয় এরকম। ইনিশিয়াল পয়েন্টগুলো দূরে দূরে হয়, পরের দিকে পয়েন্টগুলো খুব গায়ে গায়ে হয় এরকম। ঠিক আছে, এটা দেখতে সুন্দর হলে এরকম করেছে। এবার কি করেছে, এখানে আরেকটা জিনিস দেখতে পাচ্ছি যে হাফ ওয়ে টু দ্য ম্যাক্স। ম্যাক্স মিনস যেখানে এটা প্যারালাল হচ্ছে তার যে হাফ, সেখান থেকে একটা পয়েন্টকে এক্সট্রাপোলেট করা হচ্ছে গ্রাফের উপরে টু এক্স অ্যাক্সিস। যেখানে কাট করছে সেটাকে বলা হচ্ছে Km. So Km basically কি? What is the unit of Km? The unit is equal to the unit of substrate concentration. তাহলে কি হবে? moles per liter. তাহলে what is Km? এই গ্রাফ থেকে কেউ বলতে পারবে what is Km? Km is the substrate concentration at which the reaction velocity of the reaction is half the maximum. Half the maximum. Right? এবার এইখানে আসি, এই ডায়াগ্রামটাকে বলা হয় স্টেডি স্টেট কাইনেটিক্স। কি বলা হয়? স্টেডি স্টেট কাইনেটিক্স। সেটা কি জিনিস? সেটা হচ্ছে এই পুরো গ্রাফটা একটা রিয়াকশনের শুরু থেকে শেষ পর্যন্ত দেখানো হয়েছে। ভালো করে লক্ষ্য করো, এখানে কতগুলো লাইন রয়েছে। ফার্স্ট লাইন রয়েছে সাবস্ট্রেটের, ইনিশিয়াল সাবস্ট্রেট কনসেন্ট্রেশন হাই যখন শুরু হচ্ছে, তারপর যত রিয়াকশন হচ্ছে টাইমের সঙ্গে সঙ্গে এটা কমছে, কমে 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 জিরো হয়ে গেল, সব সাবস্ট্রেট শেষ, রিপিটেড। প্রোডাক্ট জিরো থেকে শুরু হলো, বাড়লো, বাড়তে 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 এক সময় গেল হাইয়েস্ট পৌঁছালো। কোথায় পৌঁছালো? সাবস্ট্রেটের সঙ্গে একই লেভেলে পৌঁছালো। ধরে নাও ইউনিমলিকুলার রিয়াকশন, তাই না? হলো। এবার ফ্রি এনজাইম, ইনিশিয়ালি কনসেন্ট্রেশন ইজ হাই, তারপরে কি হচ্ছে? এটা কমছে। কেন কমছে? কারণ কিছু এনজাইম সাবস্ট্রেটের সঙ্গে ইন্টারঅ্যাক্ট করছে, তাই ফ্রি এনজাইমের পরিমাণ কমে যাচ্ছে, তাই কমে গিয়ে একটা জায়গায় দাঁড়ালো, কিন্তু জিরো হয়নি, তাই তো? জিরো হয়নি। সেটা এই পর্যন্ত মেনটেন করলো। তারপর যখন সাবস্ট্রেট কনসেন্ট্রেশন আরও কমতে শুরু করলো, তখন সেটা বাড়তে বাড়তে আবার ইনিশিয়াল কনসেন্ট্রেশন চলে আসলো। কেন আসলো? কারণ আমরা জানি এনজাইম ডু নট পার্টিসিপেট ইন দ্য রিয়াকশন, ইট মেনটেন্স ইটস ওন কনসেন্ট্রেশন ইনিশিয়ালি অ্যান্ড অ্যাট দি এন্ড অফ দ্য রিয়াকশন। সেম, কারেক্ট? ইএস কমপ্লেক্সও ঠিক তাই, এনজাইম মতন রিয়াক্ট করবে, ইনিশিয়ালি বাড়বে, তারপর একটা কনস্ট্যান্ট মেনটেন করবে, তারপর একটা যখন সাবস্ট্রেট কমে যাবে তখন সেটা আরও কমে যাবে। এইখান থেকে এই পর্যন্ত এই জায়গাটায় যদি আমরা কোনো কিছু মাপি তাহলে আমরা কী পাবো? ভি ইকুয়াল টু ডিএস ডিটি করে কী পাবো? ডিএক্স ডিটি কী পাবো? 0। তার মানে কি? নো চেঞ্জ ইন কনসেন্ট্রেশন নাইদার ই নর ইএস। এই জায়গাটা বলা হয় কি বলা হয়? ডিএক্স ডিটি, মানে ডিইএস অর ডিই ডিটি দুটোই 0 হবে। দের ইজ নো চেঞ্জ ইন দ্য কনসেন্ট্রেশন। তার মানে কি মনে হতে পারে? রিয়াকশন স্টপ করে গেছে। তা না, রিয়াকশন ইজ টেকিং প্লেস, তাই একে বলা হয় স্টেডি স্টেট কাইনেটিক্স। তা কি বলবো আমরা এখানটায়? আমরা এখানে বলবো দিস ইজ কল্ড স্টেডি স্টেট কাইনেটিক্স বিকজ অ্যাট দিস মোমেন্ট এই দুটো পয়েন্টের মধ্যে, কোন দুটো পয়েন্ট? এই পয়েন্টটা আর এই পয়েন্টটা, ডিইএস ডিটি আর ডিই ডিটি এরা 0. That signifies that it is maintaining a constant rate of DES and DT. Right? মানে যতটা ES তৈরি হচ্ছে ততটা ES আবার ইউটিলাইজ হচ্ছে সেই হিসেবে। এটাকে বলা হয় স্টেডি স্টেট কাইনেটিক্স। যে কোনো রিয়াকশনে একটা এরকম স্টেট থাকে। বোঝা গেল? এটা কিন্তু কোশ্চেন এরকম আসে, হোয়াট ডু ইউ মিন বাই স্টেডি স্টেট কাইনেটিক্স? সেখানে কিছুই না, আমি যেটা বললাম ছবিটা আঁকতে হবে, একে প্রত্যেকটা লাইন বোঝাতে হবে। ইচ লাইন ইউ হ্যাভ টু ডিসক্রাইব, ইচ লাইন সাবস্ট্রেট, প্রোডাক্ট, ইএস, ই, টাইম, এভরিথিং কি গ্রাফটা ড্র করেছো ইউ হ্যাভ টু ডিসক্রাইব। তারপর কি বলবে? দেন ইউ সে দ্যাট বিটুইন দিস পয়েন্ট, মার্ক করবে বডিটাকে অ্যারো দিয়ে, দিস পয়েন্ট ডিএস ডিটি ইজ ইকুয়াল টু ডিই ডিটি ইজ ইকুয়াল টু 0. That shows there is no change in the concentration of ES or E during this period. This period is called steady state kinetics. That does not mean the reaction has stopped, but reaction is maintaining a uniform rate. ওইগুলো ওগুলি বলা আছে, এগুলি দরকার নেই, আমরা যাবো না এগুলিতে। এখানটা আসবো, এটা ভালো করে লিখে রাখো, এইটা এটা পরীক্ষা আছে। কি আছে? লাইন উইভার বার্ক প্লটটি লেখো। হোয়াট ডু ইউ মিন বাই লাইন উইভার বার্ক প্লট? তাই না? অর ডাবল রেসিপ্রোকাল প্লট। হোয়াট ডু ইউ মিন বাই লাইন উইভার বার্ক প্লট অর ডাবল রেসিপ্রোকাল প্লট? কোথেকে আসবে? এই ইকুয়েশন থেকে আসবে, মাইক্রোস্কোপিক ইকুয়েশন থেকে। V0 is equal to Vmax into S divided by Km plus S. কি করবো? প্রথমে দুটোকে ইনভার্ট করে দেবো, 1/V আর ওদিকে হয়ে যাবে Km plus S divided by Vmax into S. এবারটাকে ভাগ করে নেবো, Km একদিকে চলে গেল, S একদিকে চলে গেল, তাহলে Km by Vmax plus S into S, আর ওখানে S by Vmax into S. S নিজেকে নালিফাই করবে, Km and Vmax থাকবে, তাহলে 1/V0 divided by Km by is equal to Km by Vmax into S আর 1/Vmax. এই ইকুয়েশনটা কেমন দেখতে? y is equal to, রাইট? তাহলে এটা কিসের গ্রাফ হলো? ইকুয়েশন হলো স্ট্রেট লাইন, তাই তো? তাহলে সুবিধা কি হলো? আগে ছিল এরকম, এখন হয়ে গেল এরকম স্ট্রেট লাইন। এবার স্ট্রেট লাইন হয়ে গেলে আমরা যে রিয়াকশনের যে কোনো পয়েন্টের কনসেন্ট্রেশন মাপতে পারবো খুব সহজে, কারণ সেটা স্ট্রেট লাইনে রয়েছে। যদি প্যারাবোলিক হয় তাহলে খুব মুশকিল, হাইপারবোলিক হয় মুশকিল। এটা কেন করলাম এটা? ফর দ্য ইজ অফ ক্যালকুলেশন, ফর দ্য ইজ অফ ক্যালকুলেশন, নাথিং এলস। এছাড়া কি আর কোনো মডেল আছে? আছে, এডি হফস্টিন মডেল। আরও আছে এরকম স্ট্রেট লাইনে আরও মডেল আছে, এডি হফস্টিন মডেল। আমরা একটা মডেল বলছি, এটা মানে এটাই শেষ নয়, এটা বলার উদ্দেশ্য এটাই শেষ নয়, আরও মডেল আছে, কিন্তু আমরা লাইন উইভার বার করতেই সাধারণত দেখি। বুঝতে পারছিস কেন দেখি? আমার পছন্দটা এখনো কারণ। সিগনিফিকেন্স অফ কেএম, হোয়াট ইজ কেএম অ্যান্ড হোয়াট ইজ ইজ সিগনিফিকেন্স? তাড়াতাড়ি বলছি শোনো, খুব সহজ ব্যাপার। কেএম মানে কি? কেএম হচ্ছে সাবস্ট্রেট কনসেন্ট্রেশন অ্যাট হুইচ the rate of the reaction is half the maximum. Correct? What does it signify? It signifies the affinity of the enzyme towards the substrate. It signifies affinity of the enzyme towards the substrate. Affinity মানে আসক্তি, আসক্তি, তাই না? ভালোবাসা, কতটা তাকে ভালোবাসে, সাবস্ট্রেটটাকে কতটা ভালোবাসে। যে সাবস্ট্রেটটাকে বেশি ভালোবাসবে সে কি করবে? অল্প সাবস্ট্রেটটাই অ্যাক্টিভেটেড হয়ে যাবে। আর সাবস্ট্রেট যদি বেশি ভালো না বাসে, মানে লো অ্যাফিনিটি হয়, তাহলে কী হবে? সাবস্ট্রেট অনেক বেশি লাগবে, তাই না? তুই যদি বিরিয়ানি ভালোবাসিস, তাহলে তোকে হাফ প্লেট বিরিয়ানি দিলে তুই খুশি হবি, তাই না? আর তুই যদি বিরিয়ানি ভালো না বাসিস, তাহলে তোকে এক প্লেট দু প্লেট দিলেও তুই খুশি হবি না, তাই না? বুঝা গেল ব্যাপারটা? তাহলে অ্যাফিনিটি সঙ্গে সম্পর্ক কীরকম? ইনভার্স সম্পর্ক। অ্যাফিনিটি তো বাড়বে, কেএমটা তো কমবে। কারণ কি? কেএম মানে কি? সাবস্ট্রেট কনসেন্ট্রেশন, তাহলে কম সাবস্ট্রেটে অ্যাক্টিভেট হয়ে যাবে। বুঝে গেল? এইবার একটা ছোট্ট প্রবলেম আসে, সেটা হচ্ছে গ্লুকোকাইনেজ আর হেক্সোকাইনেজ। হেক্সোকাইনেজ কি করে? গ্লুকোজ থেকে গ্লুকোজ 6 তৈরি করে, ফ্রাক্টোজ থেকে ফ্রাক্টোজ 6 তৈরি করে, গ্যালাক্টোজ থেকে গ্যালাক্টোজ 6 তৈরি করে। কি করে? হেক্সোকাইনেজ। আর গ্লুকোকাইনেজ কি করে? গ্লুকোজ থেকে গ্লুকোজ 6 তৈরি করে, ফ্রাক্টোজ থেকে ফ্রাক্টোজ 6 তৈরি করে না, গ্যালাক্টোজ থেকে গ্যালাক্টোজ 6 করে না, খালি গ্লুকোজ থেকে গ্লুকোজ 6 তৈরি করে। ক্লিয়ার? গ্লুকোকাইনেজ থাকে লিভারে, আর হেক্সোকাইনেজ থাকে লিভার ছাড়া বাকি সব টিস্যুতে। রাইট? হয়ে গেল? তাহলে একজনের কেএম হচ্ছে 10 মিলিমোলস, আর একজনের কেএম হচ্ছে 0.2 মিলিমোলস। তার মানে কি? দ্য এনজাইম হুইচ ইজ মোর স্পেসিফিক টুয়ার্ডস গ্লুকোজ, তার অ্যাফিনিটি টুয়ার্ডস গ্লুকোজ কম দ্যান দ্য এনজাইম হুইচ ইজ লেস স্পেসিফিক টুয়ার্ডস গ্লুকোজ। তাই তো মানে দাঁড়াচ্ছে কার অ্যাফিনিটি বেশি? গ্লুকোজের প্রতি হেক্সোকাইনেজের বেশি। স্পেসিফিসিটি কার বেশি? স্পেসিফিসিটি কার বেশি? গ্লুকোকাইনেজ। তাহলে উল্টো ব্যাপারটা হয়ে গেল না? একটু কেমন কেমন লাগছে না? তাই না? যে খালি বিরিয়ানি খেতে পারে তার বিরিয়ানি পোতর ওপরে লোভটা কম, আর যে বিরিয়ানি ছাড়া অনেক কিছু খেতে পারে তার বিরিয়ানির উপর লোভটা বেশি। এবার ভালো লাগছে? কারণটা কি? কারণটা হচ্ছে এদের মেটাবলিক অ্যাক্টিভিটি, কেন কোথায় কি দরকার সেটার উপরে নির্ভর করছে। গ্লুকোকাইনেজ ইজ ফাউন্ড ইন লিভার, হেক্সোকাইনেজ ইজ ফাউন্ড ইন এক্সট্রা হেপাটিক টিস্যু। ঠিক আছে? এবার যখন আমরা খাবার খাই, আফটার উই টেক ফুড, আমাদের ব্লাড গ্লুকোজ লেভেল টেন্ডস টু ইনক্রিজ, রাইট? So there all cells whoever require glucose they will take up. Now what is the function of liver? Liver এর ফাংশন হচ্ছে for glucose to collect excess glucose and store in the form of glycogen. Now if the liver glucokinase had lower Km like hexokinase, then what would have happened? No extrahepatic tissue would have received any glucose because liver would have taken all the glucose. তাই না? লিভারের কাজ কি? এক্সেস গ্লুকোজটাকে ব্যবহার করা, নট টু ইউটিলাইজ গ্লুকোজ বাট টু ইউটিলাইজ এক্সেস গ্লুকোজ। সেখানে যাতে বাকি টিস্যুগুলো রিসিভ করে, সে জন্য লিভারের যে এনজাইমটা থাকবে তার কেএমটাকে বাড়িয়ে দেওয়া হয়, নট দ্য সিলিং, অ্যাবভ দ্য সিলিং। ইউ ক্যান ইমাজিন, তাই না? হি ডিড দিস, ক্যাপিটাল হি, রাইট? So he did this in such a way so that liver will be active only when glucose concentration is very, very high and it is excess after the utilization of all the tissues. Then only glucokinase will take up the glucose from the blood and will convert it into glucose 6-phosphate, which most of it will go to synthesis of glycogen. When glucose level is low, it will not take up glucose. It will leave glucose for the use of extrahepatic tissue. Clear? Now we come the fifth one or sixth one. Types of inhibitors. Fifth one. Inhibitors. Now types of inhibition, these are the major classification of inhibition. In some books, they refer as two types of classification, reversible and irreversible. If you consider in that way, the first three comes under reversible and last one comes under irreversible. Reversible means which can be reverted back. Irreversible means which cannot be reverted back. The enzyme is damaged forever. Enzyme is damaged forever. Right? You need to synthesize new enzyme molecule in order to increase the rate of reaction. Because those enzymes already produced, they are damaged. They are somehow blocked irreversibly. They cannot be brought into action any further. Clear? So reversible can be of three types: competitive, non-competitive and uncompetitive. The non-competitive has got another name called mixed inhibition. Competitive, uncompetitive and third one non-competitive or mixed inhibition. Fourth one irreversible. আরো আছে আরো different types of inhibition আছে কিন্তু molecular mechanism wise এইগুলোকে এই চারটে ভাগেই ভাগ করা যায় রিভার্সিবল ইরিভার্সিবল আমি বলি যে রিভার্সিবলটা ব্যবহার করা উচিত না কারণ হচ্ছে in many cases these models may lead to irreversible conditions. Competitive inhibition. Whereas inhibitor is structural analog to the substrate. Structurally, they are similar to that of the substrate. So instead of substrate, they go and compete with substrate for binding into active site. Whoever comes first, enzyme take it without any discrimination. Now if the enzyme takes, suppose the reaction, any enzymatic reaction occurs in this mechanism. Enzyme and substrate, they always collide. The speed of the collision will increase with temperature. If temperature increases, correct? If temperature decreases, same thing will happen, but slowly. The temperature increases, change in form of energy. When temperature increases in such a manner that it crosses the activation energy, the collision energy dissipated by the collision crosses the activation energy, then the reaction takes place. Correct? Now, suppose there are 100 molecules of substrate. Now, 50 of them have been replaced by 50 molecules of inhibitors. That means chance of getting heated by substrate now is half per collision. If the composition, if the concentration of inhibitors is further increased, then chance will be further less than half. So the product formation will be decreased accordingly. Clear? So this is nothing but a structural, due to structural similarity, the inhibitors will bind to this thing. Now this is called flow chart. Whenever you write this kind of question about inhibitors, you must draw this flow chart and explain accordingly. What is that? See, in straight line, E plus S, ES, EP. Clear? Other line, E, free enzyme. Remember, not ES complex. Free enzyme, enzyme should be in free condition to bind with the inhibitor in case of competitive inhibition. So that it binds in form EI or enzyme inhibitor complex, which leads to no product, which leads to no product formation. So in complete inhibition, the inhibitor binds only to the free enzyme, not to S complex. This is the vital line. Lineweaver-Burke plot-এ গ্রাফটা কেমন দেখতে হয় আমরা মনে রাখবো। রেড লাইনটা হচ্ছে বেস লাইন, রেড লাইন মানে বেস ইকুয়েশনের ইকুয়েশন। এবার এই যত আমরা কনসেন্ট্রেশন বাড়াবো ইনহিবিটরের তত এই ব্লু লাইনটা তৈরি হবে, স্লোপ বাড়বে, তাই না? নেগেটিভ স্লোপ বাড়বে, দেখো নেগেটিভ স্লোপ বাড়ছে, নেগেটিভ স্লোপ তো ওয়াইজগুলি mx প্লাস সি মানে গ্রাফটা এরকম হবে, আর মাইনাস সি হলে এরকম হতো, তাহলে এরকম হবে। যত সিটা বাড়বে তত এরকম পড়ে যাবে, তাই তো? তোদের কোজ হবে, ছবিটা আঁকিছিস? আঁকতে হবে তো, এটাই ছবিটা আঁকতে হবে, এটাই ইম্পর্টেন্ট। যে ইনহিবিটর দিলে আস্তে আস্তে সেটা অ্যাক্সিসের কাছে আসবে, এই মানে অরিজিনের কাছে আসবে। তার মানে কি হবে? অরিজিনের কাছে আসলে কি হবে? দেখ, ওয়াই অ্যাক্সিসে কোথায় ক্লিপ করছে? 1/v max। এক্স অ্যাক্সিসে যেখানে ক্লিপ করছে সেটা হচ্ছে 1/km, 1/km। When it approaches towards origin, that means km will be less. Now this is minus 1/km. তাহলে km বাড়বে না কমবে? বাড়বে। km will increase. Vmax এর কোনো চেঞ্জ হবে? হয়েছে কোনো চেঞ্জ? Vmax এর চেঞ্জ হয়নি। তাহলে Vmax will remain constant or unchanged and km will increase. তাহলে দুটো রিয়াকশন যদি km ইনক্রিজ করে একই গ্রাফে, তাহলে কি বুঝবো? একে অন্যের ইনহিবিটর, সেটা কম্পিটিটিভ ইনহিবিশন হচ্ছে। বোঝা গেল? এনি কোশ্চেন? এটা মাইনাস 1/km আর এটা মাইনাস 1/km ড্যাশ। তাহলে km ড্যাশ ইজ গ্রেটার দেন km, আমরা এবার লিখতে পারি, তাই তো? Vmax will remain same, no change, but kmটা কি? km ড্যাশ হয়ে গেল, তাহলে km ড্যাশ ইজ গ্রেটার দেন km, এই গ্রাফ থেকে আমরা বলতে পারি। ক্লিয়ার? এনি কোশ্চেন? গুড। এক্সাম্পল, এটা খুব কমন এক্সাম্পল। এটা কি বলা হয়? পাবা, প্যারামাইনো বেঞ্জোইক অ্যাসিড। কি করে? সালফার ড্রাগ, সালফার ড্রাগ কি? এইটা সালফানিলামাইড। এটা এক ধরনের অ্যান্টিবায়োটিক বা অ্যান্টি মাইক্রোবাল এজেন্ট। অ্যান্টিবায়োটিক বলে না, অ্যান্টি মাইক্রোবাল এজেন্ট বলে, ঠিক আছে? অ্যান্টিবায়োটিক মানে অরিজিনাল অর্গানিক সোর্স থাকা উচিত। এটাকে ধরে নে অ্যান্টি মাইক্রোবাল এজেন্ট। এটা ব্যাকটেরিয়াকে মারার জন্য ব্যবহার করা হয়। এবার দেখ, ফলিক অ্যাসিড is vital for our cell to survive. Folic acid is required for DNA synthesis. Folic acid is equally required for bacteria. Now, we eukaryotes cannot synthesize folic acid. We get it from our diet. But bacteria are self-sufficient. They can synthesize their own folic acid, and that's why they die. We target the same machinery which synthesizes folic acid in bacteria's body. So when you give the sulfur drugs to a patient, it does not affect the patient. It affects the bacteria present in the patient's body. Because bacteria is going to synthesize folic acid from para-aminobenzoic acid. Now this para-aminobenzoic acid is structurally similar to this compound, sulfanilamide. So sulfanilamide goes and blocks to the enzyme and compete with PABA. So what happens? No folic acid is synthesized. So bacteria dies due to failure of multiplication or replication. ব্যাকটেরিয়া থেকে বাচ্চা ব্যাকটেরিয়া তৈরি হতে পারে না। এই বুড়ো ব্যাকটেরিয়া বয়স হয়ে মরে যায়। বুড়ো ব্যাকটেরিয়া বয়স হয়ে মরে যায়। একে বলে ব্যাকটেরিয়া স্ট্যাটিক এজেন্ট। যে ব্যাকটেরিয়া আছে সেই ব্যাকটেরিয়া মানে মানে তাকে মারছি না, তাই খালি কি করছি? তার বাচ্চা কাচ্চা হতে দিচ্ছে না। তো সে যখন বুড়ো হবে মরে যাবে, তার বাচ্চাটা থাকবে না, তাই তো? তাকে আমরা বলি ব্যাকটেরিয়া স্ট্যাটিক এজেন্ট। আর যদি কাউকে গুলি করে মেরে দিয়ে গেল ব্যাকটেরিয়া সেটা। আর কি আছে? কম্পিটিটিভ ইনহিবিশন থেকে আরেকটা কোশ্চেন আছে, খুব কমনলি, সেটা হচ্ছে ইথানল অ্যান্ড মিথানল। এই ক্ষেত্রে কোশ্চেনটা এরকম আসে যে ইথানল, কোশ্চেনটা এরকম আসে, ইথানল is used as a therapeutic agent. Explain. Ethanol is used as a therapeutic agent. Methanol এবং ethanol, both being alcohol, are acted upon by enzyme alcohol dehydrogenase in the liver. তোর ঘুমোলো লাস্ট বেঞ্চ, জল খা একটু, জল খা, তোকে বলছি জল খা, ড্রিঙ্ক ওয়াটার, ওকে একটু জল দে বাবা, তুই জল দে একটু ওকে, সে কি, drink water. Methanol and ethanol both are acted upon by alcohol dehydrogenase and they are converted into the corresponding acid. Methanol is converted to methanaldehyde, methanol, and then from the methanol to methanoic acid or formic acid. Formic acid. Ethanol is converted to acetaldehyde and from acetaldehyde is oxidized to acetic acid. Now which one is more harmful? Formic acid or acetic acid? Why? Do we take acetic acid? Do we eat acetic acid? Yes, vinegar. Every time we take Chinese food, we take vinegar. Correct? Or any pickle, we take vinegar. So vinegar is not at all harmful. But formic acid is very harmful. So formic acid is so harmful. It is found in whose bite? Ants. Very good. So formic acid is very harmful. It affects optic nerve. That's why by drinking poisonous or spurious alcohol, people lose their eyesight. বিষাক্ত মদ খেয়ে অমুক জেলাতে 100 জন নিহত, এরকম খবর এই শীতকালে চলে আসতো টাইম। The time has come when we'll receive this kind of news in the newspaper. Spurious or unauthorized liquor consumption kills 100 in the so-and-so district. This story, the time has come when we'll receive this story in the newspaper very often. This winter time. What happens? Ki hoy, while boiling, during fermentation of process, fermentation produces many alcohol. Methanol, ethanol, propanol, butanol, etc., etc. When distillation, the maintenance of temperature should be maintained very narrowly, very strictly. If the temperature increases, then instead of coming ethanol, collecting ethanol, we collect methanol. If the temperature decreases, instead of collecting ethanol, we collect, along with ethanol, we collect propanol. Propanol doesn't cause any harm, but methanol causes harm. Right? So that's why temperature for distillation process should be maintained very strictly, and that cannot be monitored in an unauthorized sector. So people eat spurious alcohol and they get affected by methanol. In that case, ethanol should be given IV. Uncompetitive first, then we'll come to non-competitive, mixed one later. This is what? This is a flow chart. Which one? Uncompetitive. Uncompetitive. Competitive, then uncompetitive, then non-competitive. Uncompetitive, enzyme plus substrate. Inhibitor binds with enzyme substrate complex, not free enzyme. Correct? After the binding of substrate, the conformational change of the enzyme happens in such a manner that it binds with inhibitor again. And result is no product. What is the change in this graph? See, the y-axis intercept goes away from the origin. That means Km decreases, Vmax decreases, Km decreases, Vmax decreases, it becomes parallel. Last one, non-competitive or mixed. Why mixed? See, inhibitor can bind either with free enzyme or with ES complex, both. That's why it is called mixed. Clear? Inhibitor can bind either with free enzyme or with enzyme substrate complex. So it is mixed. In both cases, they form enzyme substrate inhibitor complex. Either through this way or through this way. But ESI does not produce any product. ESI complex থেকে কোনো প্রোডাক্ট তৈরি হয় না, তাই এখানে আমরা কি বলবো? মিক্সড ইনহিবিশন অর নন কম্পিটিটিভ। যদি আনকম্পিটিটিভ নন কম্পিটিটিভ কনফিউজ হয়ে যাও তাহলে মিক্স কথাটা মনে রাখবে, ঠিক আছে? গ্রাফটা কেমন হবে? এরকম। এবার এই গ্রাফটার মধ্যে একটা মজা আছে। সে মজা কি? সেটা হচ্ছে দিস গ্রাফ ইজ অ্যাকচুয়ালি আ স্পেশাল কেস ওয়্যার all the points are jutting out from same point of the x-axis. Actually, গ্রাফটা কিরকম হতে পারে? এরকম হতে পারে। যদি কোথাও এরকম গ্রাফ দেখো তাহলে ভয় পাওয়ার কোনো কারণ নেই। আমি ভুল পড়াইনি, তোমরাও ভুল যাও না। সেটা কি? এই একটা গেল, কারেক্ট? নাও এই যে গ্রাফটা রয়েছে, এই গ্রাফটার একটা স্পেশাল কন্ডিশন হচ্ছে যখন এক্স অ্যাক্সিসটা এখানে, বোঝা গেল? সেখানে হলো, দেখো সেরকম আছে, তাই না? তাহলে এই ক্ষেত্রে কি হচ্ছে দেখো, কেএম, এটা কেন করা হলো বোঝার সুবিধার জন্য, এই দিস লেভেল, যে কেএম যেন সেমই আছে, খালি ভিম্যাক্স চেঞ্জ করছে। তাহলে কি তফাৎ হলো? নন কম্পিটিটিভ কোনগুলো চেঞ্জ হলো? বোথ কেএম এন্ড ভিম্যাক্স ডিক্রিজেস, আর এই ক্ষেত্রে ভিম্যাক্স ডিক্রিজেস। তফাৎ বোঝা গেল? তিনটে তফাৎ। এইটা করার জন্য একটা স্পেশাল কেস এইভাবে দেখানো হয়েছে তোমাদের সুবিধার জন্য। অ্যাকচুয়ালি গ্রাফটা এরকম, ঠিক আছে? দিস আর স্পেশাল কেস। এক্সাম্পল দেওয়া আছে, দেখে নাও। এগুলি খুব একটা জিজ্ঞেস করে না, একটু কঠিন, তাই তো একটা করে এক্সাম্পল মনে রাখা উচিত, ঠিক আছে? হলো? এবার কি বাকি রইলো বলতো? ইরিভার্সিবল। দেখো ইরিভার্সিবল হচ্ছে এক্সাম্পল হচ্ছে, গ্রাফটাকে ওটাকে দেখালাম না নাকি? ইরিভার্সিবল একটা স্টাফ ছিল তো এখানে, এক্সাম্পল গুলোকে বাদ দিয়ে চলে গেলাম। ওহো, হ্যাঁ এই দেখো, এটা বাদ দিয়ে চলে গেছি, বুঝো? যাও এটাকে বড় করে দেবো বাবা, থ্যাংক ইউ। ঠিক আছে, ইরিভার্সিবল কি হচ্ছে? ইনহিবিটার অ্যান্ড সাবস্ট্রেট এরা একে অন্যকে কম্পিট করে, ভালো কম্পিট করে এক জায়গায় বসলো, বসার পরে ইনহিবিটার কি করে, সাবস্ট্রেট কি করে? সাবস্ট্রেট এনজাইমের সঙ্গে কোনো সলিড বন্ড তৈরি করে না, কিন্তু ইনহিবিটার রিয়াকশন হয় এনজাইমের সঙ্গে বাইন্ড করার পরে। রিয়াকশন হওয়ার পরে এমন একটা প্রোডাক্ট তৈরি করে যেটা খুব টাইটলি ইনহিবিটার এনজাইমের সঙ্গে বেড়ে যায়। যেমন একটা এক্সাম্পল দিই, যেমন অ্যালোপিরিনল। অ্যালোপিরিনল জ্যান্থিন অক্সিডেজ বলে একটা এনজাইমকে ইনহিবিট করে। জ্যান্থিন অক্সিডেজ কি করে? ইউরিক অ্যাসিড তৈরি করে। কি তৈরি করে? ইউরিক অ্যাসিড। তা কারোর শরীরে যদি ইউরিক অ্যাসিড বেড়ে যায়, তার ইউরিক অ্যাসিড কমানোর জন্য কি বলবো আমরা? জ্যান্থিন অক্সিডেজ ইনহিবিটর দেবো, তাই তো? সেটার নাম কি? অ্যালোপিরিনল। সে কি করবে? সে অ্যালোপিরিনল গিয়ে ওই জ্যান্থিন অক্সিডের সঙ্গে বাইন্ড করবে, করে অ্যালোজ্যান্থিন তৈরি করবে। কি তৈরি করবে? অ্যালোজ্যান্থিন। ওটার কাজ কি ছিল? জ্যান্থিন থেকে ইউরিক অ্যাসিড তৈরি করা। আর এ কি করবে? অ্যালোজ্যান্থিন তৈরি করলো ইনহিবিটরটা। অ্যালোজ্যান্থিন ইনহিবিটর এনজাইমের সঙ্গে খুব স্ট্রংলি বাইন্ড করে যাবে, তারপরে এনজাইমটা থেকে আর বেরোবে না। তাহলে কি হলো, এনজাইমটা রিয়াকশন করলো ঠিকই, করে মরে গেল, মানে সুইসাইড ইনহিবিশন। কি হলো, সুইসাইড ইনহিবিশন, ইররিভার্সিবল। ঠিক আছে, এটা একটা এক্সাম্পল সুইসাইড ইনহিবিশন, যেখানে ইনহিবিটর বাইন্ড করছে এনজাইমের সঙ্গে, করে রিয়াকশন করে এমন কম্পাউন্ড তৈরি করছে যেটা মোর টাইটলি বাইন্ডস উইথ এনজাইম and irreversibly, so that enzyme are no more functional. Hello? So inhibitors, in case of suicide inhibition, inhibitors renders enzyme non-functional by binding with them permanently. যেভাবে বলো। হলো, আরেকটা এক্সাম্পল দেওয়া যাক। একটা কম্পাউন্ড আছে DIPF। এই গ্রাফটাপগুলো আঁকার দরকার নেই, ইরিভার্সিবল একদম আঁকার দরকার নেই, অত ডিটেলস আমার নেই, লাগবে না। এক্সাম্পলগুলো মনে রাখবি, পরীক্ষা আসবে। আরেকটা এক্সাম্পল দিই, এই কম্পাউন্ডের নামটা মুখস্থ কর, ডাই আইসোপ্রোপাইল ফসফোফ্লোরিডেট। কি বললাম, তাই না? ছোট নাম না? হ্যাঁ, এর থেকেও ছোট একটা নাম আছে, কি বলতো? কোলেস্টেরলের কি রিং থাকে? সাইক্লোপেন্টানো পারহাইড্রোফিনান্থিন রিং। হ্যাঁ, তাই না? এরকম ছোট ছোট নাম থাকবে কয়েকটা, আরো ছোট ছোট নাম পাবি ভবিষ্যতে। এই ছোট্ট একটা নাম DIPF, ডাই আইসোপ্রোপাইল ফসফোফ্লোরিডেট। এই কম্পাউন্ডটা কি করে? এই কম্পাউন্ডটা করে হচ্ছে যে আমাদের শরীরে বেশিরভাগ মোস্ট অফ দি proteolytic enzymes, digestive enzymes which digest protein, are serine proteases by classification. মানে they have a serine group or threonine group at their active site, মানে catalytic site. Correct? If this compound goes and binds with those serine and threonine residues, they bind it irreversibly and thereby render the enzyme inactive. এনজাইমের সঙ্গে বাইন্ড করে এনজাইমকে ইনঅ্যাক্টিভ করে দেয়। তাহলে এনজাইমটা রিমেন্স নো মোর অ্যাক্টিভ টু বাইন্ড উইথ অ্যানাদার মলিকুল অফ প্রোটিন, সো ইট ক্যানট ফাংশন। তাহলে ডাইজেস্টিভ এনজাইমসের ইনহিবিটর হিসেবে কাজ করা হয়। কাকে করা হয়? DIPF। তাহলে ইফ উই ডিসকভার আ নিউ এনজাইম and we find the activity is lost after adding DIPF, that means the enzyme falls to serine proteases, that group, serine protease গ্রুপের মধ্যে পড়ে। ক্লিয়ার? দুটো এক্সাম্পল হয়ে গেল, যথেষ্ট হয়েছে। পেনিসিলিন, এটা এক্সাম্পল, এটা তোমরা হায়ার সেকেন্ডারিও পড়েছো, পেনিসিলিন কি কাজ করে, তাই না? আচ্ছা, আর শেষ হয়ে যায় মোটামুটি, দেখলাম এটা। আচ্ছা, লাস্ট কি ছিল? কোফ্যাক্টরস, তাই না? এটা আমি আগের দিন নিয়েছি, পড়ে নিয়েছি না? কি কোফ্যাক্টর কাজ করে? What are the cofactors? Name of the vitamins, cofactors, coenzyme forms.
Today we are going to perform a test for identification of protein in our sample. You already know it is a qualitative test because here we are not going to measure any kind of substances in our sample. Okay? And the one important test is heat coagulation test. Heat coagulation test. You tell the principle of heat coagulation test. Stand up. Tell your name. Yes, Misra. Okay, tell the principle of heat coagulation test. Today we are going to perform a heat coagulation test. Okay. And you know the principle because I already tell you about this principle. It is a general reaction of the protein in which when we change the temperature of the solution, the protein present is change their structure, change their biological function capability by changing their structure, and it forms a coagulum. Or to check whether it is a coagulum formed by the protein or phosphate or sulfates, we add 1% glycerol acetic acid dropwise. So this is the procedure. Now you read the procedure, you read the principle very carefully, and be selective from one by one to perform this activity.
টেস্ট টিউবে 2/3 পার নেবো, সেটা হিট করতে হবে। তার জন্য বাইরে প্রেস করবে, সবসময় বাইরে প্রেস করবে, তারপরে আর টেস্ট টিউব সবসময় বেঁকিয়ে নেবে। রিয়েজেন্ট যেন টেস্ট টিউবে গা দিয়ে দেওয়া হয়। ঠিক আছে, এটা 2/3 পার এটা হিট করতে হবে। আপার পার্ট হিট করবে, ঘুরে ঘুরে হিট করবে।
এটা হোল্ডার লাগবে না ধরার জন্য,
এটা বিনা হোল্ডারে করতে হবে। চলে আসছে, ফোন করছে। এবার প্রোটিন কি প্রেজেন্ট আছে সেটা দেখার জন্য গ্লাসে দিতে হবে। এই ফর্মে যখন আসবে তারপরে তুমি গ্লাসটা অ্যাসিড মিশাবে। তোমাদের টেবিলে কিন্তু গ্লাসে অ্যাসিড দেওয়া আছে সব জায়গাতে, কিছু কিছু জায়গাতে নেই, নিয়েছে। আর রিয়েজেন্ট যখন ড্রপার হিসাবে যখন কোনো রিয়েজেন্ট দেবে সবসময় উপর থেকে দেবে। অনেক সময় হয় আমাদের ঢেলে নিয়ে দেখুন এই মানে আছে এখানে আছে
with the his or her immunity foamy in nature, মানে even the perspective that এটা খেলার মতো হয়ে যাচ্ছে। আরেকটা হয় যদি সাবস্টেন্সটা কমে যায়, এই ক্ষেত্রে দেখো তোমার প্রোটিনটা নিয়েছো, তোমার সলিউশন যেটা ছিল তোমার হিট করে দিলে, হিট করে নিয়ে সেরকম একটা সলিউশন দাও, ঠিক আছে। তুমি জল নিয়ে করে এরকম ফ্রথিং হবে না, তুমি যত ঘষবে তত এটা ফ্রথিং বাড়বে, এটা যতটা ডাইলিউট হবে ততটা এই ফ্রথিংটা কমে যাবে। এবারে দেখো তুমি এটা নিচে হবে মোটামুটি ধরা হয়, হিট টেস্টটা করতে হবে, পুলিশের মারের নাম। আর এই ইউরিনটা মোটামুটি আমাদের কালার এরকম থাকে। ইউরিনে নর্মালি বলে দিচ্ছি, নর্মালি ইউরিনের পিএইচ অ্যাসিডিক থাকে, ঠিক আছে। অ্যাসিডিফাই করার কোনো দরকার নেই, কিন্তু তোমাদের যেটা লেখা আছে 2 to 3 ড্রপ দিয়ে অ্যাসিডিফাই করতে হবে, অ্যাসিডিফাই করবে। অ্যাকচুয়ালি ইউরিনে যদি হিট করা হয় তাহলে ইউরিনের দুটো কন্ডিশনে, টু কন্ডিশনস where the turbidity will appear. One is phosphate and another is protein. First one is protein, second one is phosphate. In alkaline urine, phosphate is precipitated. Suppose in the situation where the urine is alkaline and if you do a heat test, it will cause turbidity because of the phosphate. Now if you add acid to it, it will get dissolved. We want to see in this test specifically acid. That's why we don't want to see the phosphate. That's why we acidify. Otherwise, it is not required. You can see in a normal test, first and foremost, you have to check the pH before acidifying. Too much acidification will be of no help, because too much acidification will cause acid metaprotein, which is not coagulable. Even if you increase the heat, it will not come out. That is a big problem. So during heating, just see, while heating, you have to take care that this upper part of the test tube, just like this, so that here the concentration is much less. But still, it will cause turbidity. Can you see the turbidity?
Yes, sir.
This type of turbidity will come. In the examination, you will not get this, or in real sample, of course you will get it.
Yes, sir.
So we can heat at one part. The problem is that if you heat at one part, there might be bumping. That's why uniform heating is there. Now the protein, the solution adjacent to this thing is now hot, and the protein will also get coagulated because of the heating. Okay, so this is urine positive. This part of, can you see the difference? You can come to the light. Then the color of the urine will be almost watery because there will be dilution of the urochrome, and it will, you have seen, you will restrict the water intake, then it will be yellowish. So if you take too much of water, it will be almost like this. You see, this is a thick precipitate, and that will determine, since some amount has already precipitated, so that indicates a higher amount of protein. This is a massive proteinuria, because when the disease is advanced, at that stage, this type of thing will occur. In the early stage, we will get this type of cases. As the disease progresses, and if it remains untreated, or even after treatment, it doesn't respond to the treatment, then only a higher amount of urine will be excreted in the by the kidney because of the increasing disease process. So that will cause appearance of large amount of urine, protein in the urine. So there are 3 varieties. One is normally the amount of protein we do excrete, that is up to 150 microgram per day. Okay, but that is not detectable. So albuminuria is called, normal albuminuria is 3 to 30, up to 30. That is normal. Beyond that, 30 to 300 mild, and above 300 it is a massive albuminuria. So for that we require a separate test. So this is a little bit crude test where the amount is much higher, almost more than 300 microgram per deciliter. Okay, here you will not get protein by this test, but it does contain protein, and that can be detected by a method which are having a higher sensitivity. See, I'm just giving a simple example. Give me a piece of paper, a small piece of paper, suppose by which we weigh vegetables. Can it weigh?
No, sir. No, sir.
Do you think it is not? It doesn't have any weight. It has weight. So for which we require a balance which will be more sensitive. If you weigh gold by a machine, not by the common machines, if you put it there, it will show a weight. If you put it by the laboratory machine, it will show more precise. So even if I divide it into 1,000 parts, that will have an weight. That can also be measured. Okay. So for that we require a higher kind of sensitive, highly sensitive instrument. These are very costly. So that part will be taught during whosoever will be doing specialization in biochemistry or whosoever carrying out research work. For that it is required. And I have done it in the micro concentration, 5 microgram. That much urine I have measured also. That much protein I have measured. Do this practice repeatedly. Otherwise, once you will not, it will be perfect. It will not be perfect. তখন ঠান্ডা হবে ঠিক আছে
স্যার গরম থাকলে
না গরম থাকলে এটা পাবে why this is coming down. Tell me why this white is spreading below. Why the white precipitate is moving downwards? Denaturation has already problem তৈরি হয়ে গেছে, denaturation হয়ে গেছে, and this is irreversible denaturation. Denaturation some can be reverted back to original state, that is renaturation. In this case, by due to heating, it cannot be taken back to original form. This is the irreversible form of zero. So why it is coming down? Target was initially here, now it is coming down. Why? Acetic acid is soluble in water. Huh? Then it's time to explain why this experiment is coming down. Why something gravitates? Why something gravitates? Why something moves down below the solution? Why? It is gravitating. The precipitate is gravitating downwards. It is having higher weight than that solution. That side is coming down. It has formed a problem. Protein in which form? Protein remains, that albumin remains in the solution. Tell me, in which form? Is it a true solution or a colloidal solution? Why do you call it colloidal solution? Chitra, are you sure? Why do you call it colloidal solution? Why it is called a colloidal solution? What is it? What is the size? मुझे बोला सुन ले दास सुन ले वो इतने काला था actually true solution 10 to the minus 7 था that 10 to the minus 3 is the upper limit maximum because in protein there is a layer of hydration and that gives albumin solution. Now that part you have cognitive. Basically by heat you have denatured albumin. So that third cell structure which I taught in the class, that all the polar groups which were remain outside that albumin molecule now got destroyed because of heating. Because as I told, the third cell structure is maintained by non-covalent interactions. All these electrostatic bond, hydrogen bond, that are all supports. So these have been broken down. So it has come to secondary stage. Primary stage is still restored. So because of that, solubility has decreased. The large protein will no longer be in solution if it is reacted. If its tertiary structure is lost by any means, be it acid, you can make an acid precipitation also. If you add sulfursulfuric acid, that is also an acid, that will cause the same reaction. Also, if sulfuric acid is there, you add sulfuric acid to the solution and just shake it, it will get feasible turbidity uniformly. This is a very easy bedside test. You see, nowadays, many dipsticks are available, where they use sugar and candy and multiple parameters can be seen at a glance. You put that strip into the urine, or if you directly pass urine onto the strip. In the OPD procedure, in gynecology obstetrics department, to detect sugar and protein in a pregnant woman, whether they are excreting protein or urine in urine, they are given a strip. And that strip, they are asked to go to the toilet and just simply pass urine on and bring it the strip. So from the strip, they get the idea. There is no need to go to the laboratory. Now, why this test is different? Because at times this strip might not be working properly. That might get damaged. So you must have a control mechanism. You must have a control mechanism. So these are the gold standard tests. Now, if you do the testing, heat testing, or the further superior testing, then you will be able to detect. Then you can talk to the company that this heat is not working. That is the reason why some fundamental concepts are required. All of you are from Bengali medium school. You are from English medium school. What is 1 meter? Define 1 meter. What is 1 meter? Can anybody tell? Can anybody tell what is 1 meter? 100 centimeter. 100 centimeter. Anybody else? Anybody wants to modify? How many of you are from English medium school? you are. See, rest. Hindi medium, English medium. Oh, language is same. I mean, only is that you have to translate. See, I am from Bengali medium school. I read this thing in class 9. What is a meter? Is that? Voila, this is the definition I want. You are trying, you are getting into the point. 90%. Class 9 full everything you have to remember. Clearly. Let's try to, I will help you. She got into the area. That is 1 meter. Similarly, for everything there is a gold standard. For everything there is a gold standard. That is the reference point. Yes, which we have to compare. Bolo, try to recall. Why it is located in which country? I found that in Paris. Paris is the place. Right. What is the association? What is the organization? International Bureau of Weights and Measures. That is the reference point. What is 1 meter? That difference. Okay. So that's why there is a reference point. Right? Busy? You know, Papa knows how to do.
As you can see, I have written it is the second most common form of cancer in males, followed after lung carcinoma. And if you are asked about the prevalence, then you will say it is common after 50 years of age. So hardly you get to see any patient with a prostate carcinoma in the younger ages. For example, in renal cell carcinoma, you can see patients at a very young age presenting with RCC. But you will not find usually a case of prostate carcinoma before the age of 50 years. Now, it has been seen that when a patient reaches the age of 80 years, then almost 50% of them will be having some foci of prostate carcinoma. It may not be symptomatic, it may not be detected clinically when the patient was still alive, but then around up to 50% of patients at the age of 80 years are bound to be having some form of prostate carcinoma, which has been established by studies. So, as you can see, there are certain types, so certain classifications based on clinical presentation of prostate carcinoma. The first one is latent carcinoma. What is latent? That means the patient in his lifetime never presented with any form of carcinoma, neither clinically nor detected by any other means when the patient was living. Now the patient died due to some other cause and an autopsy was conducted. In the autopsy, it was found that the patient had prostatic carcinoma. So definitely the patient who didn't present with any symptoms, else investigations would have been conducted for prostate carcinoma. So patient died, and after the death, at the time of autopsy, obviously we are not doing autopsy for every patient who are dying. So maybe there was some other indications for doing autopsy, and at the time of autopsy, it was diagnosed that the patient had prostate carcinoma. So that is what we call as latent carcinoma. Is that clear? That is latent carcinoma. Next, we have incidental carcinoma. Incidental means that the patient had a biopsy of prostate for another indication, the most important being BHP. And in that biopsy, you found out that the patient had a focus of prostate carcinoma. So the patient did not present primarily with symptoms of prostate carcinoma, but he had a biopsy for another prostatic condition. Commonest is BHP. It may be prostatitis or any other conditions, but commonest is BHP. And in that biopsy, you find that the patient had a focus of prostate carcinoma. So that is what we call as incidental. Next, occult. What is occult? That is, the patient had no signs, symptoms of prostate carcinoma, but there is a metastasis. So, suppose the patient has presented with bone pain, and while evaluating the bone pain, you are finding that the cells that are present in the bone, for example, vertebra, they are of prostatic origin and they look like malignant prostate carcinoma cells, and then you come to the inference that the patient had prostate carcinoma. So primarily the patient had no symptoms of prostate carcinoma, but at the time of, but straight away presented with metastasis. So that is what we call as occult carcinoma. And last is the commonest one, that is clinical carcinoma. Clinical carcinoma is the one that is the patient presented with symptoms, and then you did a digital rectal examination, and there you found out that the patient is having prostate carcinoma. So these are the types of prostate carcinoma that we usually get to see. Now, etiology is important because sometimes you often get a question regarding what are the commonest etiologies of prostate carcinoma. So then there are actually 5 points. So you have to elaborate a little bit on each of the points. First is endocrinologic factors. Endocrinology, the commonest hormone or the hormone that is usually responsible is androgen. So as I have written over here, the androgen is essential for development and maintenance of the prostatic epithelium. So if there is overproduction of androgen, or there is overactivity of the androgen receptors, anyway leading to increased function of androgen, then there is a risk that the patient can develop prostate carcinoma. So it has been established that androgen is a causative factor endocrinologically for the development of prostate carcinoma. And what are the evidences for this theory that androgen is responsible? So it is seen that in a case of prostate carcinoma, if you do orchiectomy, that is, you remove the testis. So you remove the source of androgen. So then there is regression of prostate carcinoma. The second point is, in the therapy of prostate carcinoma, sometimes we are giving estrogen. So that will result in blocking some of the effects of androgen, and that will in turn result in your diminished action of androgen and therapeutic advantage. So one is you either remove the testis, that is called orchiectomy, or you give exogenous estrogen to the patient. Both these cases, you are actually diminishing the action of androgen, and that has been shown to be beneficial to patients who are having prostate carcinoma. So that is the most substantial evidence in favor of the fact that androgen is responsible for development of prostate carcinoma. So other than that, patients with Klinefelter syndrome or patients with this UNUX, that is the patients who are the people who are already having diminished androgen, they never develop it. It is seen that they usually don't develop prostate carcinoma. And lastly, you can see that it is seen that the years when androgen is at its highest level, that is the time prostate carcinoma is developing. And in very elderly patients, suppose 80 years, 70 years, their prostate carcinoma is remaining at a latent stage, because at that point of time, again, the level of androgen is falling. So around 50, 60 years, say the patients are developing carcinoma, but then a patient who is 80 years of age or say 85 years of age, then since the level of androgen has naturally declined, therefore the patients will remain, the carcinoma will remain latent. That is, the signs, symptoms and the presentation of the carcinoma will be quite low as compared to the patient who had developed a carcinoma at the age of 60 years. So older the age of the patient, the better the prognosis of the patient. So that is the endocrinologic factor that is primarily based on androgen. Next is racial and geographic. It is seen that worldwide, this is a worldwide distribution of prevalence, that is Chinese, Asian men, that is Chinese or Japanese, they are rarely developing prostate carcinoma. But it is more common in Americans. In the Caucasian race, it is more common. Even in Americans, there is a division, that is African Americans, they are having a higher prevalence than the Caucasians. So just remember that Asians, they are normally not developing prostate carcinoma. Asians as in Japanese, Chinese. However, it is more common in the Western population, and that too more among the whites than among the blacks. However, in India, the prevalence is pretty high. As I have told you, just after lung carcinoma, the second most common is prostate. So the prevalence of the disease must be high. What is the other point? Environmental. So polycyclic aromatic hydrocarbons. So these are some of the risk factors. That is, all these, if you are having it in the environment, mainly in the diet, then that is a positive factor that is responsible. And if you add selenium and flavonoids and antioxidants, then it is expected that may have some protective action or protective result in your prevention against prostate carcinoma. But normally we are not just adding selenium to our diets just to avoid prostate carcinoma, but this is just for theoretical purpose. You can remember that polycyclic aromatic hydrocarbons, that is a risk factor, and flavonoids and this selenium antioxidants, they have a protective effect. Just for your exam purpose, you can remember these few names. Next is nodular hyperplasia a cause? That is an important question because many patients are having nodular hyperplasia. Many patients, you will find that after 50 years or 60 years, mostly the patients are having nodular hyperplasia, which we call BHP. The term has changed, it is now BHP. So BHP, so is that a risk factor? Then the answer is no. The answer is no, because your BHP is developing from the periurethral area, and prostate carcinoma is from the peripheral part of the prostate. So the site of origin are completely different. But just like I told you that there is something called incidental carcinoma, which means that a patient had BHP, on top of that he had this prostate carcinoma, but then it is not considered that the BHP led to the prostate carcinoma, meaning BHP is not a precursor lesion for prostate carcinoma. But often we find that since BHP is very common and patients get evaluated after certain years of life, that those patients who get evaluated for BHP, sometimes they have an incidental finding of prostate carcinoma. So BHP is not a causative factor, but BHP can be associated with prostate cancer. In case you find that is the case, that BHP is associated with prostate cancer, then you are going to say it as a incidental carcinoma. And last point, hereditary. Hereditary is that first degree relative, if they are having prostate carcinoma, then there is twofold chance that the patient might develop a prostate carcinoma. If a first degree relative is having a prostate carcinoma, then there is twofold chance. And it has been seen that there is this familial clustering. This is familial clustering. That is, in a family, some first degree relative is having, and then this twofold chance, there is first degree, that is familial clustering. And if you are asked about is there any genetic predisposition, then you can talk about BRCA2 gene. BRCA2, it has a 20 times increased prevalence of prostate carcinoma. Means it has been seen that compared to the general population, if BRCA2 is present, then have you heard about BRCA1 and BRCA2? BRCA1 is important in which cancer? Anybody knows? Breast. So BRCA1 is breast. Another? Ovary. So BRCA1, that is breast, ovary, those are important. And BRCA2 is, in case of prostate cancer, it is in the 20-fold higher incidence, risk, 20-fold higher increased risk of incidence of prostate carcinoma. So these are the etiological factors. We have this question coming up in your exams, theory exams. What are the etiological factors? 5 points you just remember, and in brief you describe. So repeating once again, that is endocrinologic. You will talk about androgen. Then racial, you will say that Chinese, Japanese, usually they are not having it, but Americans, they are having the prevalence more. Then you can talk about African Americans greater than Caucasians. Then after that, the next point was, I think, environmental, where you will say polycyclic aromatic hydrocarbons, they are the risk factor, and preventive factor is your flavonoids, selenium, and antioxidants. After that, whether nodular hyperplasia is a risk factor or not, you will say no, but then it can be associated. If it is associated, it is called incidental carcinoma. And lastly, I have talked about familial. Familial, you will talk about that first degree relative, then 2 times higher chance, BRCA2 present, then 20 times chance. So there is obviously a familial clustering. That is the etiology. This is the histogenesis or pathogenesis, whatever you say. So what is the precursor lesion? Precursor lesion of prostate carcinoma, that is called PIN. PIN stands for prostate, this is prostatic intraepithelial neoplasia, that is the PIN. This is your precursor lesion. That is, what is PIN? The definition of PIN is multiple foci of atypical luminal cells overlying diminished layer of basal cells, diminished number of basal cells within the prostatic ducts. So, you have seen the normal architecture of normal histology of prostate. There are the ducts. Those are lined by basal layer and then luminal layer of cells. If the luminal layer is, that is the cells that are pointing towards the lumen, and basal layer is this outside layer. BHP hoye gache to. Benign prostate is over. So you must have seen the normal histology of prostate. In that case, what have you seen? That is, there is an outer layer of basal cells and inner layer of luminal cells. If the luminal cells are becoming atypical, but the basal layers are still present, they might be diminished in number, but the basal layer is still present and the luminal layer is becoming atypical. Then that is called prostatic intraepithelial neoplasia. That is again divided into two parts, that is low grade and high grade. If it is low grade, then low grade will give rise to high grade, and high grade will give rise to your adenocarcinoma. So that is what we call as prostatic intraepithelial neoplasia. That is the precursor lesion. Now, come to this second part. Genetic level. At the genetic level, what is happening is there are two things going on. One is your epigenetic phenomenon, and another is your somatic mutation. Epigenetic phenomenon means there is hypermethylation. There is hypermethylation of this particular gene, that is GSTP1. So, hypermethylation of GSTP1, and that is resulting in loss of function of the GSTP1 gene. GSTP1 gene is usually responsible for your detoxification of carcinogens. So, GSTP1 will cause detoxification of carcinogens. Now, GSTP1 is having loss of function. Why? Because there is hypermethylation. So, that is what we call as epigenetic alteration. And secondly is your somatic mutation. Somatic mutation, what happens is there is mutation. Okay, there is mutation of this ETS family of genes, and that results in, there is a fusion. What is it? TMPRSS2 and ETS. So, so ETS family of transcription genes, transcription factor genes, it places the TMPRSS2 and this ETS fusion. Now, TMPRSS2, what is the importance? Is a promoter gene. So, whenever you are overactivating a promoter gene, TMPRSS2 and ETS, whenever the fusion occurs, then TMPRSS2 is a promoter gene. So, you are overactivating the promoter gene due to fusion. This fusion results in overactivation. So, there is increased increased risk of carcinogenesis. So, what happens is GSTP1 that normally detoxifies the carcinogens. Here, that GSTP1 is having loss of function due to hypermethylation, and TMPRSS and this TMPRSS gene and ETS fusion, whenever it is happening, that is what happens is there is a promoter gene is getting overactivated. So, one is you are removing the gene that is protective, and you are causing hyperactivity of the gene that is responsible for carcinogenesis. So that is how at the genetic level, this is the pathway for your prostate carcinoma. Now, okay, so this is a picture for this. This is a picture for prostatic intraepithelial neoplasia. This is not given in your books. So what happens is, as you can see, please follow the pointer. This is the outer layer. Can you see there are two layers? That is this layer. This is the outer layer. You see the cells. Compare this cell with this cell. There is a difference. This cell and this cell. This is a basal layer of cells, and this is your luminal layer. Okay, so this is the luminal layer, and this is your basal layer. So just like I told you that you find this, there is atypia in the luminal layer. Obviously, if you can compare, this is not normal size of the cells, isn't it? There is a nuclear enlargement. There is some kind of pleomorphism. There is some kind of atypia. So the luminal cells have become atypical, but you can still find the basal layer. Basal layer cells are cuboidal. You can see at the periphery there are cuboidal cells. So this basal layer, there is this cuboidal cells. They are still present, and the luminal layer has become atypical, and this is what we call as prostatic intraepithelial neoplasia. Next, this is a gross picture of prostate. So what happens is, in the prostate, normally in other cancers, the size of the organ is increasing if there is a carcinoma. But in this case, it can increase, it can remain the same, it can even decrease. So you had this, did you have a class on testis? Testis carcinoma, is it over? Okay, so can you tell me one of the cancers, one of the subtypes of cancer testis where there is decrease in size of the testis, although it is a carcinoma? For example, in seminoma, the size of the testis is increasing. Say embryonal carcinoma, it is increasing. Then in which case the size will become diminished. Just like I told you, in prostate, the size might get diminished. The size might get reduced even if it's a carcinoma. Anybody knows which subtype of testis? Whether actually the testis becomes smaller, even though it is a choriocarcinoma. What happens in choriocarcinoma? Have you read? So this is the entire prostate that has been removed. The entire prostate has been removed, and you will find that this is firm and fibrous in consistency. That is, at the time of sectioning, you will find the consistency to be firm, fibrous, and as you can see, there is yellowish consistency. These areas, it has become a yellowish homogeneous. So these are the areas of carcinoma. Normal prostate what is it? Fibromusculoglandular organ. So it will look like this. So as you can see that in all these cases where there is this arrow pointed, so it contains irregular homogeneous areas. So whenever you find a homogeneous area in any kind of specimen, then you have to be careful that there must be some pathology over there. Because whenever there is homogenization, then the normal architecture must be lost, must be effaced. That's why there is a homogeneous architecture. So you will say that grossly, you will say it arises from the peripheral part of the prostate, number one. Number two, you will say that the size can be larger, can be normal, or it can be even smaller. Then you will say on cutting, that is on cut section, it is firm, fibrous, and then you will say that there are yellowish homogeneous areas, irregular yellowish homogeneous areas in the prostate. So these are the gross features, as you can see in this picture. Okay, so this is microscopy is very important. Please look at the microscopy. There are 5 points. Microscopy, that is, what happens is, this is an adenocarcinoma. The prostate is a glandular organ, So it will arise from the glands, the carcinoma arising from the glands. So this is an adenocarcinoma. So what are the architectural abnormalities happening? First is architectural distortion, okay, or disturbance, whatever that is. So normally we see there is intra-acinar papillary proliferation. Normally, see, even if you go to the picture for this one, see, this is a acini. So there is papillary proliferation inside the acini. There is papillary proliferation. That is the normal architecture. Even if you see a gland of BHP, you will find that the glands are dilated and then tortuous, and there is intracinar papillary proliferation. So the first point is that will be lost. So papillary convolutions, proliferation, whatever you say, that will be lost. That is the first architectural disturbance. The papillary convolutions will be lost. And what will be the architecture then? That is back-to-back acini. Closely packed, back-to-back acini with loss of papillary convolutions. That is the first point. The second is stroma. I've written the second is stroma. So what happens is, normally between the glands you have stroma. And what is the character of the stroma? That is fibromuscular. So is a fibromuscular stroma between the glands. That is the normal architecture. But here what happens is that is lost. So you will find it again back to back. Or the stroma might be present, but that is not fibrous or fibromuscular, that is desmoplastic. So the character of the stroma will either change, or you will find that there is no stroma at all around the glands. So that is the stroma. Next is the cells. So next is the gland pattern. Gland pattern, what does it mean? That normally the normal glands of the prostate you will no longer be found, and based on the pattern of glands, they are divided into well differentiated, moderately differentiated, poorly differentiated. But that is as per your books, as per your Harsh Mohan and everything, it is written well, moderately and poorly. But right now, while reporting, we are using the Gleason pattern. I will talk about that little later. So what happens is well differentiated. What does that mean? That is, the glands, they are composed of this one. So they are small to medium sized glands, and they are lined by single layer of cuboidal cells, cuboidal to low columnar, small to medium sized glands. Individual glands are formed, that is, there are well formed glands. You will still find the presence of glands. The glands are well formed, they are lined by single layer of cuboidal cells, and your back to back small to medium sized glands. That is the well differentiated. Moderately, what happens? You will not find well defined glands. So there will be cribriforming. I will just come to it after a little while, what is cribriforming. So the glands are the normal rounded well formed glands are lost, and you will find cribriforming of the glands. And poorly differentiated, that is no glands at all. So either there will be single cells present in the stroma, or there will be solid or trabecular arrangement of the glands. Trabecular means again solid proliferation. There is a certain shape of the certain shape to it, and that's they are called trabeculae. So if you find that normal glands are formed, but they are small to medium sized, and they are lined by single layer of your cuboidal cells, then it is well differentiated. If there is formation of cribriform pattern, then, or fenestrated cribriform, the same thing, then that is the moderately differentiated. And if there is no glands at all, it is a solid proliferation, or there are single cells in the stroma, scattered single malignant cells. So that is the poorly differentiated. Okay. And next point is tumor cells. How do the tumor cells look? This is very important, because unlike other malignancies, for example, if you are looking at a, say, pancreatic adenocarcinoma or a hepatocellular carcinoma, you will find that there is extreme degree of pleomorphism. So you can look at the cells and tell this is a malignant cell. But in this case, the anaplasia or atypia, the degree of that is not that much. So you just have to take into account all the factors and then decide this is a carcinoma or not. So what happens is, regarding the cells, the most important thing is that the outer layer of basal cells are lost. So normal glands have luminal cells, basal cells. When it is a pin, the luminal cells are becoming atypical, basal cells are still present. They are diminished, but they are still present. The moment you find there are no basal cells, single layer of cells, then highly suspicious of malignancy. So the first point is basal layer has to be lost. That is the first point. What is now cells? What is the characteristic of the cell? There are usually of three types. It can be either clear cells, or it can be dark cells, or it can be eosinophilic cells. Usually there are three types. I will show you a picture, you will understand. So what happens is clear cells, they will have a foamy type of cytoplasm, that they have become fully clear or dark, that is basophilic, or they have become eosinophilic. So in all the three cases, you will find that they have lost their normal character of the normal cells. And the last is your invasion. Invasion is that you will find in the slide, there is presence of perineural invasion. You might find lymphovascular invasion, but then often you are finding perineural invasion. That is, there are nerve bundles. Surrounding the nerve bundles, you are finding tumor cells. Or within the nerve bundle, you are finding tumor cells. So, architectural disturbance, that is loss of the normal papillary convolutions present within a normal acini. That is architectural disturbance. Next is stroma. You will not find back-to-back glands. No fibromuscular stroma between glands. Next is the glandular pattern. It can be of three types. Either well-formed, small to medium-sized glands that are lined by single layer of cuboidal to low columnar cells. That is the well-differentiated. In the moderately differentiated, either fenestrated or cribriform pattern of glands. And in the poorly differentiated, no gland formation at all. So what is happening is a solid proliferation of cells or single proliferation of cells. Next is how will the cells look? That is, there is the anaplasia or the atypia is not much, but then what is there? No basal layer, and the individual cells can be of three types. Either it will become clear, or it will become dark, or it will become eosinophilic. If it is clear, then that is called it will be having a foamy cytoplasm. If you get a basophilic nature, then you will find the cells will become very dark, and eosinophilic will have a granular cytoplasm. Lastly, we will find that there is presence of perineural invasion, that is nerve bundles. Around the nerve bundles or within the nerve bundles, you will find tumor cells. And you might also find lymphovascular invasion. There is endothelial line spaces and containing tumor cells. So this is very important for the microscopy of prostate carcinoma. So now the pictures. So this is a normal gland. Is this a normal gland? See, so you just see this is the shape of a normal gland and compare this with these glands. As you can see, there is single layer of cells. And what is the nature of the cells? Are they of similar quality? Compared to this, don't you find these are a little darker? So you can say that these are, see this you can call eosinophilic. Then in this picture, see, these have become darker, so maybe they are the basophilic variant, that is the darker cells. And I haven't got a picture of clear cells over here. But as you can see that if you compare in the periphery of the slide with normal glands, then you can appreciate that there is a change in character of the cells. So they have become small to medium sized. They are lined by single layer of cells. There is no peripheral surrounding by basal cells. And obviously, there is some degree of atypia. You can appreciate the nuclei are larger than the normal sized gland. So this is a well differentiated adenocarcinoma, and this pattern is right now being told is renamed as Gleason pattern 3. Gleason pattern 3 is just the same as well differentiated adenocarcinoma. This is moderately differentiated. What has happened is this is a cribriforming of glands. So you can see there is no well-formed nature of the glands can be seen. Individual glands, there is a sieve-like appearance to the glands. That is, within the glands, it's called cribriforming, or I have used the term fenestrated appearance of the glands. So throughout the slide, you can see that no well-formed glands are seen, and then the glands are like having this kind of a fenestrated or this kind of appearance, and that is called cribriforming. And this is right now being called as Gleason pattern 4. Pattern 3, 4, 5, well, moderately and poorly differentiated. this is the poorly differentiated. So what happens is, these are all tumor cells. Within the stroma, they are all tumor cells. So single cell proliferation of the tumor. There is no gland formation, no cribriforming forming or anything, but then throughout the entire stroma you are finding the cells. So, and there are areas where there are solid proliferations also, like this. Some of the areas there may be solid proliferation. So you can see that this is the fibromuscular stroma, but in between them you can find the tumor cells. Fibromuscular stroma, within that the tumor cells. So this is a poorly formed, poorly differentiated, and this is called Gleason pattern 5. So 3, 4, 5. Okay, now spread. Spread is like, you have to understand, just like any other tumor, there is local spread, and distant spread. So what is local? That is, it will, the prostate has a capsule, so it will breach the capsule and it will spread locally. Locally, where will it go? Locally, you have to understand, you have to think about the surrounding structures. That is your bladder neck, seminal vesicle, trigone, ureteral openings. So it will be spreading to the surrounding structures, bladder neck, trigone, seminal vesicle, ureteral openings. And distant spread is important. Distant spread is by lymphovascular invasion. That is by lymphatic route as well as vascular route. So this is important because a lot of cancers, just like I told you, they are presenting straight away as metastasis. So if they are presenting straight away as metastasis, you will pick up the metastasis first, and then you will find the primary cancer. So lymphovascular is, if it is spreading by lymph node, then the first draining lymph node will be your obturator lymph node. So the first lymph node that will be affected will be your obturator, and after that you will have all these like sacral, iliac, para-aortic. Obturator, then sacral, iliac, para-aortic. That is by lymphatic spread. Then if you are then by vascular spread, the commonest one is the bone metastasis. Bone metastasis, the type of metastasis is osteoblastic. For example, kidney, what kind of metastasis? Kidney, what is the kind of metastasis that is presenting in the bones? Blastic or lytic? Lytic. So this is blastic. And so that is, and aside from bones, you will find other organs like brain, liver, lungs. So brain, liver, lungs, those are the other areas of spread by vascular invasion, but the commonest one is the by your hematogenous spread to the bones, and the kind of invasion is osteoblastic. Osteoblastic metastasis into the bones. Then you have the clinical features. How will the patient present? That is, usually patients are asymptomatic, but then they come to you with presence of hematuria. Hematuria is like okay, so what happens is dysuria, retention of urine. So like they will present to you mostly with the symptoms associated with prostatic hyperplasia. Almost the same presentations that the patient will come to you. So the point is like there will be retention of urine, then there will be your increased frequency. So all symptoms that you can recollect, think about in case of prostate hyperplasia, BHP, you will think of all that along with that hematuria. So with all these features, the patient can present with you, and then what will happen is that you will do a digital rectal examination. In the digital rectal examination, you will find that there is a nodular growth that is fixed to the surrounding structures. So that is a very diagnostic feature. In BHP, in BHP, it's diffuse hyperplasia, but then here you will get a nodular growth that is firm and fixed to the surrounding structures. So when the patient comes to with all these symptoms, and you do a digital rectal examination, and you will find that fixed heart, fixed kind of feel, then you will think about prostate carcinoma, and then comes your lab work. What happens is, there are two things given. One is prostatic acid phosphatase, PAP, and another one is PSA. Okay, so prostatic acid phosphatase and prostate specific antigen. Of the two, normally we are doing, clinically we are doing the PSA levels only. PAP is mostly your theoretical purpose. We are not doing it regularly in the labs. So PAP is prostatic acid phosphatase. You will measure the serum level of prostatic acid phosphatase, and those cancers that have extended beyond the capsule, they will have raised PAP. But prostate specific antigen, that is a PSA, that is a more important. PSA, we are measuring it in the serum as well as by immunohistochemistry. So what happens is PSA we are regularly doing for any case of prostate carcinoma or any case of BHP. We are ordering a PSA. PSA is 0 to 4 is normal. Then 4 to 10, if the level you are getting of PSA, there is a 10% risk of having prostate carcinoma, and more than 10 is a highly suspicious or almost diagnostic. Normally, we are getting PSA in the levels of say 80, 90 in those cases which are presenting to us with prostate carcinoma. So your focus will be on PSA. What happens is you will measure the serum levels of PSA. From that, you will get an idea whether the patient is having prostate carcinoma or not, because there is a quantitative range. 0 to 4 normal, then 4 to 10% risk. More than 10, you have this highly suspicious, and usually, as I told you, the 80, 90, 100 even we are getting PSA for some patients. And one important thing is the high-grade tumors, they're having a lower PSA than the low-grade tumor, that you must remember. But then that is you are going to see on histology, whether high-grade or low-grade, just you are going to order a PSA. And second important thing is that suppose you are evaluating a tumor in the say surrounding areas and you don't know. For example, you are seeing a bladder tumor and you are unsure whether this is a bladder origin or prostate origin, then you can do a IHC for PSA. That is, first one I told you was measurement of serum levels of PSA. But if you do IHC for PSA, then you can say this is a prostate origin. So PSA, two important uses. One is based on the level of PSA, you can say whether this is a carcinoma or not. That is number one. Second is if you do IHC in the tissue, then you can say this is a prostate origin. So metastasis from prostate and not a primary bladder or something when you are confused. So these days, what are we doing? A patient that has come to you with presentation of prostate carcinoma, we are doing three things. First of all, we are doing a digital rectal examination. First thing is we are doing the urologist. When a patient presents with the urologist, he is doing a digital rectal examination. And then he is finding hard fixed nodule that is fixed to a surrounding structure. So he is getting highly suspicious. Then he is ordering a PSA. PSA levels, if they are raised, then there is almost diagnostic of PSA. And then the last and the gold standard is you have to do a truss-guided two-cut biopsy. So transrectal ultrasound-guided biopsy, and in that biopsy, you are going to confirm or stamp that the patient is having a prostate carcinoma or not. So these three things you must remember. If asked in the exam, how do you diagnose? Digital rectal examination, PSA, and this that is the biopsy. Lastly, just few minutes. See, Gleason's histology grading. This is, I don't think this is there in your books, but then this is not a very important thing for at your level. So just understand that what is happening is we have three things. One is the Gleason pattern, one is the Gleason score, and one is the Gleason grade group. Pattern is what? Like I told you, well differentiated is your pattern 3, moderately is pattern 4, and poorly differentiated is pattern 5. So based on the pattern, suppose in a biopsy, you are getting this. What does this mean? The score 3 plus 3, 3 plus 4. That means suppose we are taking into consideration two predominant scores. For example, in a biopsy, you are having entire biopsy is of pattern 3. So you will say 3 plus 3. But suppose the majority is 3, but there is a minor component of 4, then you have to take into consideration 2 patterns. And thereby the concept of plus this is coming. Normally, in biopsies, you are getting more than one pattern. So therefore, this concept of one plus another is coming. So pattern is your fixed. Pattern is there only 3 patterns. Pattern, only 3 patterns. 3, 4, 5. And that corresponds to your well, moderately and poorly differentiated carcinoma. Now, in a biopsy, if you are getting, say, entirely of pattern 3, so then you will write score will be 3 plus 3 because the entire thing is of one pattern. Now, suppose the patient has majority is pattern 3, but there is a small amount of 4, then it will become 3 plus 4. So the score will change. For example, if it is 3 plus 3, 6, then it will fall into grade group 1. But then once the score is becoming 7, it will become grade group 2. So you're not going to be asked so much of detail, but just to understand what is this pattern and group and score and group means. So the pattern is like if it is predominantly same pattern, you are going to write this plus this. For example, predominantly cribriform, so you will write 4 plus 4 8. 4 plus 4 it will be 8. So in that case, the pattern will be 4, the score will be 4 plus 4 8, and the grade group will be your this grade group 4. Okay, just I don't think you will be asked on Gleason grading. This is more we are the ones which we are reporting in the lab. We follow this pattern, this scoring system. And lastly, you have to understand the prostate staging. Now, this is, I think the staging that is given in Harshmohan is wrong. So it has changed. This is the latest T and M staging. You are only going to remember the T stage. N and M stage you don't remember. You don't need. So this there is no T1 stage right now. In all cancers, it starts with T1. Then T1, T2, T3, T4. There is no T1 in prostate carcinoma. This is very important. We are following the AJCC 8th edition of TNM staging. As per that staging, there is no T1. Straight away starts from T2. So T2, T3 and T4. Just remember this. And T2 is again divided into T2A, B, C. One half of the prostate involved, less than 50% involvement, T1A. More than 50% of one half, T1B. Bilateral, T1C. That is your T1. Then T2 is the local spread and T3 is the distant spread. T2 local spread, what happens is invasion of bladder neck and then seminal vesicle invasion, T3A and T3B. Seminal vesicle T3B and your microscopic invasion of bladder neck, that is the extraprostatic T3A, and T4 is the a little further metastasis like rectum, levator ani muscles, and your this pelvic wall, levator ani, rectum. These are all T3. So just remember for staging, T2 starts with T2. There is no T1. T2, 3, 4. T2 is again divided into A, B, C. One side involvement less than 50% T2A. One side involvement more than 50% T1B. Bilateral is T1C. Then your local spread is T3 and distant spread is this is your T4. Okay, so that is all about prostate carcinoma.
So we have different types of the agents or drugs that mainly attack at different phases of the cell cycle so that the cancer cells can be killed or can be halted, their growth can be halted. So basically these are already done. So these are the cell cycle, already you have read about this. So these in different steps of the cell cycle, different agents basically act. Cell cycle, so there are some cell cycle specific agents and cell cycle non-specific agents. That is, some agents can act irrespective of the cells present in cell cycle phases or in specific phases. So these are the specific agents, alkylating agents, anthracyclines, camptothecins, etc. So these are the tumor kinetics log-kill hypothesis, already you have known. So now coming to the different anti-cancer drugs. So anti-cancer drugs can be divided according to their chemical structure, according to their action on different phases of the cell cycle, or according to their mechanism of action. So firstly, there are some anti-cancer drugs that can block the nucleic acid biosynthesis. So anti-metabolites, so they can be called anti-metabolites, like folic acid antagonist, example is the methotrexate. Pyrimidine antagonist, example is the fluorouracil and cytarabine. And purine antagonist, example is 6-mercaptopurine and 6-thioguanine. And ribonucleoside diphosphate reductase antagonist like hydroxyurea. So basically they act against the metabolism of the tumor cells. Next is influence the structure and function of the DNA. So there are different phases by which the progression of the cancer cells occurs, and so there is DNA replication, and these agents basically act at different phases of this replication. So these can be divided into different agents according to their structure, like alkylating agent, very important, like meclorethamine, cyclophosphamide, E-phosphamide, chlorambucil, melphalan, busulfan, nitrosoureas, etc. Then coming the platinum coordination complexes. Examples are 3, cisplatin, carboplatin, these are main, and then imatinib is also there. Some antibiotics also act as anti-neoplasia agents like bleomycin, mitomycin C. Topoisomerase inhibitors like camptothecin and podophylotoxins, and other antibiotics like actinomycin D, donorubicin, doxorubicin, etc. And there are some agents that interfere protein synthesis machinery of the tumor cells, like antitubulin. They can be divided into vinca alkaloids and taxanes. Vinca alkaloids examples are vincristine, vinblastine, and taxanes example are paclitaxel and docetaxel. These vinca alkaloids and taxanes, these are also important for you. Apart from this, some agents like L-asparaginase influence the amino acid supply to the tumor cells. And there are some agents that influence hormone homeostasis. Some of it you have already read. For example, ACRM like tamoxifen. Already you have known that tamoxifen acts in the breast cancer cells. There are flutamide and bicalutamide. Already you have read. These are the androgen antagonistic drugs. So they can be used in different types of the prostate cancers. Progesterone drugs like hydroxyprogesterone. Prednisolone is used in different phases of the cancer chemotherapy. Gonadotropin releasing hormone inhibitor like nafarelin and triptorelin when there is some types of the pituitary tumor or hypothalamic tumor. Aromatase inhibitor, again it is used in testicular or prostate carcinoma like letrozole and anastrozole. This already you have read. So these are the different endocrine drugs that can also act in different neoplasia. So first coming to the alkylating agents. Alkylating, that is they mainly causes alkylation. So these are the examples of the mecloretamine. These are the first alkylating agents, lesser used now. The most commonly used cyclophosphamide and E-phosphamide. These are very important for you. Cyclophosphamide, chlorambucin and others. Apart from this classical nitrogen mustards alkylating agents, there are other agents like nitrosoureas like carmastine, lomastine, alkyl sulfonates like busulfan, ethylamines and methylamines like altritamine and thiotepa, triazines like dacarbazine, temozolomide and procarbazine. These also acts under the alkylating agents. So alkylating agents mechanisms, they have mainly highly reactive carbonium ion intermediates. So when they enters within the tumor cells, they converted to the highly active carbonium ion intermediate, and these reactive intermediates covalently links to sites of the high electron density. So there are electron transport chain that is essential for the survival of the tumor cells, and when there is more electrons are accumulated, here these carbonium ion intermediates forms a bond. Say they form bonds with the phosphate, amine, sulfidyl and hydroxyl groups. And these chemotherapeutic and cytotoxic effects are directly related to the alkylation of these reactive amines, oxygens, phosphates on DNA. So basically these are needed for the DNA replication, DNA synthesis, and they blocks this. So these nitrogen mustards inhibit the cell reproduction by binding irreversibly with the DNA, and after alkylation, DNA is unable to replicate and therefore can no longer synthesize protein. So when the alkylation occurs with the phosphate groups, sulfidyl groups, etc., with this active intermediate, they cannot replicate the DNA, and consequently cell reproduction is inhibited and the cell eventually dies from the inability to maintain its metabolic function. So this is the core mechanism of action of this alkylating agent, most commonly the nitrosoureas. So mecloretamine already I have told, this is the first one. Mainly this is used in Hodgkin's lymphoma. In lymphoma there is a regimen is given for treatment. This is known as the MOP regimen. In MOP regimen, mecloretamine, oncovin, prednisolone and procarbazine is given. So this can be used as part of the MOP regimen in Hodgkin's lymphoma. Severe vomiting can occur. Cyclophosphamide, more commonly used nowadays, cyclophosphamide and its congener E-phosphamide. It is transformed into active aldophosphamide and phosphoramide. So these are the active agents. They mainly form the carbonium ion and they alkylates the different agents that is needed for DNA replication. And another easier to use, that this can be used orally. This mecloretamine is to be used by IV injection, but this can be given orally. So this can be used in different types of the neoplasia like Hodgkin's lymphoma, different types of the breast and ovarian carcinomas. It is less damaging to platelets, that is thrombocytopenia happens less, but alopecia and cystitis can happen. E-phosphamide is a congener which has a longer and dose-dependent T-hub. So it is used in bronchogenic, breast, testicular, bladder, head and neck carcinoma, some osteosarcoma and lymphomas. And dose-limiting toxicity of both E-phosphamide and cyclophosphamide is hemorrhagic cystitis. This is very important. So alkylating agent, nitrosoureas, cyclophosphamide, E-phosphamide, the most common dose-limiting toxicity is the hemorrhagic cystitis. Very important. So how we can prevent this hemorrhagic cystitis in those patients where these agents are to be given? We have to give an agent that is known as the mesna. So when these are used, mesna is routinely used with it. So mesna is basically a sulfhydryl compound that is excreted in urine easily. So when it is given, it binds and inactivates the vesicotoxic metabolites of the cyclophosphamide and E-phosphamide. So there are some metabolites of these alkylating agents that are vesicotoxic, that is they can cause toxicity to the urinary bladder, and that ultimately causes cystitis. Cystitis means inflammation of the urinary bladder, and it is hemorrhagic cystitis, that is bleeding occurs with urine due to the inflammation of the urinary bladder when this cyclophosphamide or E-phosphamide is given singly. So to combat this, mesna is given. Mesna have a sulfhydryl group, and when this sulfhydryl group is attaches with the active vesicotoxic metabolite of the cyclophosphamide and E-phosphamide, that will not be vesicotoxic, that will easily excreted through urine, so that the hemorrhagic cystitis will not occur. So this is very important for your exam, that why mesna is given with cyclophosphamide, or whether hemorrhagic cystitis can be prevented with any agents, and why mesna is given. Chlorambucil, melphalan is more or less similar. Busulfan. Busulfan is another highly specific alkylating agent. Important thing is hyperuricemia, pulmonary fibrosis and skin pigmentation are the specific adverse effect of the busulfan. So if you are asked that what are the chemotherapy agent that can cause pulmonary fibrosis, one example is the busulfan. This is also important. Okay. So busulfan can cause pulmonary fibrosis, skin pigmentation and hyperuricemia. Okay. Otherwise more or less similar. For melphalan, bone marrow depression also occurs. Bone marrow depression, that is RBC, WBC platelet count will be less. Lomustine is another agent that can cross the blood-brain barrier. That is important. So lomustine are effective in meningeal leukemia and brain cancer. So other alkylating agents do not cross the blood-brain barrier. Only this lomustine or carmustine, this comes under the nitrosoureas, can cross. So when there is some meningioma or meningeal carcinoma, here we can use this nitrosoureas like lomustine, carmustine. Dacarbazine is another agent that is mainly activated in liver, methylates DNA, and it is used mainly in malignant melanoma. Malignant melanoma is another hematopoietic carcinoma where this dacarbazine is commonly used. Temozolomide is another agent that can be used in glioma, that is tumor or carcinoma in the brain. So temozolomide can be used in glioma. Procarbazine, it is not a classical alkylating agent but a similar properties. They also cause chromosomal damage and they can cause thrombocytopenia and vomiting. So one important thing about this procarbazine is it can interact with alcohol and can cause disulfiram-like reactions. So already in the CNS you have read about the disulfiram-like reactions. So severe flush, severe sweating, and in fact coma or death can also occur with disulfiram-like reaction. So procarbazine is an anti-cancer drugs that can cause disulfiram-like reactions with alcohol. Next important after the alkylating agents is the platinum coordination complexes. Within these platinum coordination complexes, the three agents are there: cisplatin, carboplatin and oxaliplatin. These three agents come under platinum coordination complexes. So they have broader anti-neoplastic activity and they are mainly used in the treatment of ovarian carcinoma, head and neck carcinoma, bladder, esophagus, lung and colon cancers. So basically they act differently than the alkylating agents, but their mode of action at the last is more or less like that of alkylating agents. So they do not alkylate DNA, but ultimately they covalently bind to nucleophilic sites on the DNA and share many pharmacological attributes with these alkylating agents. The platinum analogs, these platinum coordination complexes, are mutagenic, teratogenic and carcinogenic. So these agents, though they are used as anti-cancer drugs, they are also carcinogenic. That is, they can also develop some other cancers. They are also mutagenic and teratogenic. So this should not be given in pregnancy. Cisplatin or carboplatin based chemotherapy for ovarian cancer is associated with a 4-fold increased risk of developing secondary leukemia. So this is one problem, that these are mutagenic, carcinogenic and teratogenic. So cisplatin, carboplatin, oxaliplatin, so they have platinum complexes. The activated platinum complexes again can react with the similar type of mechanism like that of the alkylating agents, that is the electron dense regions and such as sulfidyl groups, and with various sites on the DNA, again they form some intrastrand and interstrand cross links. So the DNA platinum adducts are formed. So with this DNA, like alkylating agents attaches, this platinum agents also attaches with this and form some intrastrand cross linking, so that the DNA replication cannot happen as normally. So there will be miscoding, single and double stranded breaks, and ultimately the halting of the cell cycle occurs. So cell cycle specificity of the cisplatin differs among cell types. The effects of the cross linking are most pronounced during the S phase. So this is a cell cycle specific agent, and when the cells are more dividing, like in the synthetic phase, S phase, these platinum coordination complexes are more active. So cisplatin, this is an important agent for your exams also. So cisplatin is very effective in metastatic testicular and ovarian carcinoma, widely used in many other solid tumors like lung, bladder, esophageal, gastric, hepatic, head and neck carcinoma. Cisplatin is highly emetogenic drug, that is, they can cause vomiting. So if you are asked that this name one highly emetogenic anti-cancer drug or highly emetogenic drug, a drug that can cause severe vomiting, example is the cisplatin. Again, the another most important toxicity is the renal impairment. It is very much nephrotoxic also. So cisplatin is both more emetogenic as well as more nephrotoxic, both. So kidney is affected and they cause vomiting. So this nephrotoxicity depends on total dose administered with a time span. Renal toxicity can be reduced by maintaining good hydration, that is, more IV fluid is given when this cisplatin treatment is given. Tinnitus, deafness, sensory neuropathy all can occur. Shock-like syndrome can occur during infusion. Carboplatin is again a second generation platinum coordination complex indicated mainly in the ovarian carcinoma of epithelial region, head and neck, small cell lung carcinoma. Its dose limiting toxicity is different from that of the cisplatin. It is thrombocytopenia and less often leukopenia, that is the hematotoxicity. So cisplatin causes nephrotoxicity, carboplatin causes hematotoxicity, that is, that can cause decrease in platelet count, decrease in WBC count. Nephrotoxicity, ototoxicity, neurotoxicity is low. Nausea and vomiting is also milder. Another one is the oxaliplatin. Oxaliplatin is the third generation platinum coordination complex. Its dose limiting toxicity is the neuropathy. So this is important for your exams also. So cisplatin is nephrotoxic and highly emetogenic. Carboplatin is hematotoxic, that is, they cause thrombocytopenia, leukopenia, and this third generation oxaliplatin causes peripheral neuropathy, that is, these are neurotoxic. So these three agents, the adverse effects are different. So dose limiting toxicity is peripheral neuropathy. Sensory paresthesia involving arm, legs, mouth and throat are common. Acute form of neuropathy is triggered by exposure to cold. Okay. So this is the adverse effect of the oxaliplatin. Next, coming to the antimetabolites. Within the antimetabolites, the most important is the methotrexate. Already you have read about the methotrexate in different other agents, like in rheumatoid arthritis, it is also used. So folic acid antagonists like methotrexate, purine antagonists like 6-mercaptopurine and 6-thioguanine, 6-MP and 6-TG, pyrimidine antagonists like 5-fluorouracil and cytarabine. So they have general characteristics are antimetabolites are S-phase specific drugs that are structural analogues of the essential metabolites and they interfere with DNA synthesis. Myelosuppression is the dose limiting toxicity for all drugs in this class. So all these antimetabolites when they given, they causes bone marrow toxicity. So there will be decreased RBC, WBC or platelet count. Methotrexate is a folate antagonist, already you know. So the structure of the methotrexate and folic acid are similar. So when this methotrexate is given, they are actively transported within the mammalian cells and they inhibit the dihydrofolate reductase. Already you know that dihydrofolate reductase is the rate limiting step for conversion to the active metabolite of the folic acid, that is the tetrahydrofolate or tetrahydrofolic acid. This tetrahydrofolic acid is important for different 1-carbon transfer reactions that is necessary for survival of a cell. So when we are giving this methotrexate, this dihydrofolate reductase are blocked and this tetrahydrofolic acid will not be formed. Tetrahydrofolic acid is an essential coenzyme, already we have said. The inhibition is basically a pseudo irreversible. Why it is called? Because methotrexate has 50,000 times higher affinity for the enzyme than the normal substrate. That is when it is given, ultimately the tetrahydrofolic acid will not be formed. Methotrexate has cell cycle specific action. They kill cells in the synthetic phase or S phase. In addition to the dihydrofolate reductase, they also inhibit the thymidylate synthase as well, so that the DNA synthesis is also primarily affected. However, synthesis of the RNA and protein also suffers. So these are the actions of the methotrexate. Adverse drug reaction, again myelosuppression, bone marrow toxicity. So low doses given repeatedly cause megaloblastic anemia. This is important. So when in low doses methotrexate given for long period of time repeatedly, it causes megaloblastic anemia. But high doses produce pancytopenia. Pancytopenia means there is decrease of the blood cells in all the lineages. That is whether it is RBC, granulocytes, agranulocytes, platelets, etc. So this is known as the pancytopenia. Mucositis, diarrhea, desquamation and gastrointestinal bleeding are other side effects. So leucovorin factor, when methotrexate is given, already in the rheumatoid arthritis you have already seen that you have to give some rescue treatment so that this bone marrow toxicity will be lesser. So this is known as the leucovorin rescue, where the N5-formyl tetrahydrofolic acid, also known as the cytoporam factor, is given. It is administered as a plan in methotrexate therapy. Leucovorin or folinic acid or this N5-formyl tetrahydrofolic acid is directly converted to tetrahydrofolic acid without the need of dihydrofolate reductase. So production of the DNA cellular protein occurs in spite of the presence of the methotrexate. So when this methotrexate is given, the tumor cells are affected but normal cells are lesser affected because we are giving this leucovorin. So used to rescue the bone marrow and gastrointestinal cells, mucosal cells. So again, this is an important for your exam that methotrexate, everything about the methotrexate is important. What is methotrexate, how it acts, mechanism of action, and what are the adverse effects, and how the methotrexate toxicity can be prevented by giving the folinic acid or cytoporam factor or this N5-formyl tetrahydrofolic acid, because it is directly converted to tetrahydrofolic acid without the need of dihydrofolate reductase enzymes. So when we are giving the methotrexate, that not only blocks the folic acid metabolism in the tumor cells but also in the normal cells. So ultimately that causes, if we are giving it repeatedly in low doses, megaloblastic anemia, or in high doses that can cause pancytopenia. So we have to decrease this megaloblastic anemia or pancytopenia in the normal cells. So we have to giving this leucovorin rescue so that in the normal cells, folic acid can be converted normally to the active metabolite form tetrahydrofolic acid that will continue the different 1 carbon transfer reactions. So this will be the answer. So resistance can occur in some of the cases, not important. So folate antigen, these are used, methotrexate mainly used in choriocarcinoma, was the first demonstration of the curative chemotherapy. So methotrexate is curative basically in choriocarcinoma, tumors of the head and neck, breast cancer, acute lymphatic leukemia, meningeal metastasis of a wide range of tumors. So all these cases it is used. Pemetrexate is basically a newer congener of the methotrexate, newer ones that primarily targets the enzyme thymidylate synthase. Already we have seen that methotrexate not only targets the dihydrofolate reductase, that also somehow targets this thymidylate synthase. Here the pemetrexate basically acts on this thymidylate synthase, though it is also a dihydrofolate reductase inhibitor but lesser amount, so that the adverse effects will be lesser. So mucositis, diarrhea can happen, painful itching, erythematous rash can occur in some of the cases, and dexamethasone can relieve it and pretreatment can reduce its incidence. Details is not required, but remember pemetrexate can be used instead of the methotrexate to reduce the adverse effects of the bone marrow depression. Next antimetabolite is mercaptopurine, 6-mercaptopurine and 6-thioguanine. So they inhibit the conversion of the inosine monophosphate to adenine and guanine nucleotides that are the building blocks for RNA and DNA. Already you know from the biochemistry that these are the building blocks, inosine monophosphate, adenine, guanine. So basically they block this. Used in childhood acute lymphocytic leukemia, ALL. ALL basically occurs in the children where this 6-mercaptopurine, 6-thioguanine can be used for the treatment, for the maintenance and remission. In combination with methotrexate, it can also be used in the treatment of choriocarcinoma. It is metabolized by xanthine oxidase and allopurinol dose has to be adjusted because otherwise there will be a problem in the uric acid level. It is well tolerated and more or less this is similar. Next is azathioprine. Azathioprine is an antipurine, acts by getting converted to 6-mercaptopurine. Again, all the attributes of the 6-mercaptopurine are similar. So azathioprine basically an immunosuppressant drug. Already you have read about this. This can also be used as anti-cancer drug. Fludaramine is another newer purine anti-metabolite. Again, this blocks the DNA synthesis. The DNA will be dysfunctional in the tumor cells and ultimately it dies. It is used in chronic lymphocytic leukemia and non-Hodgkin's leukemia. And adverse effects are chills, fever, myalgia, myelosuppression, etc. happens, but not so important the adverse effects. So fludaramine basically causes dysfunctional DNA. Next is 5-fluorouracil, 5-FU. So fluorouracil is an analog of the thymine. It is converted to this 5-DUMP and this inhibits the thymidylate synthase and blocks conversion of the deoxyuridylic acid to deoxythymidyllic acid. Again, these are all different steps of the DNA synthesis. So they basically antimetabolite acts in the synthetic phase of the cell cycle at the different phases of the DNA synthesis. They are used in solid tumors, especially breast, colorectal, gastric tumor and squamous cell tumors of the head and neck. Adverse drug reactions are nausea, vomiting, myelosuppression, oral and GI ulceration, peripheral neuropathy, etc. Mucosal damage and some myelosuppression can happen. So 5-fluorouracil, remember the name. Next is capacetamine. Capacetamine is an orally active product of this 5-fluorouracil. It is used in metastatic colorectal cancer and breast cancer. Hand-foot syndrome and diarrhea are prominent adverse effects. This is also important. So hand-foot syndrome, this is a syndrome that can happen with this capacetamine. This can comes in the MCQ, that is the hand-foot syndrome or hand-foot mount syndrome can occur with capacetamine. Cytarabine is also known as the cytosine arabinocyte, which is a cytidine analog of the phosphorylated in the body, and ultimately again it inhibits the DNA synthesis. It is used in acute myeloid leukemia, acute lymphocytic leukemia, blast crisis in CML and non-Hodgkin's lymphoma. And major toxic effects are due to bone marrow suppression, leukemia, thrombocytopenia, anemia, mucositis, diarrhea, etc. So cytarabine, it is also used in different types of the leukemia. Okay. Next, coming to the another antimetabolite that is known as the hydroxyurea. So hydroxyurea blocks the conversion of ribonucleotides to deoxyribonucleotides by inhibiting one enzyme that is known as the ribonucleoside diphosphate reductase. Again, it interferes with the DNA synthesis, exerts S phase specific action. It is indicated in chronic myeloid leukemia, polycythemia vera, psoriasis, in some solid tumors also. And it is also employed as a radiosensitizer before radiotherapy and is a first line drug for sickle cell disease in adults. So it is not only used only in anti-cancer drugs, only in neoplasia, but in some other usages also. For example, remember in sickle cell anemia. So sickle cell anemia, there will be HBS. So sickling of the RBC occurs. Here the hydroxyurea is used as a treatment. It is also used as a radiosensitizer. That is, you know that in neoplasia, in cancer, not only the chemotherapy, radiotherapy have to be given in some selected cancers. So before radiotherapy, the cells have to be prepared. So the cells have to be radiosensitized, and this can happen due to the usage of this hydroxyurea. Myelosuppression is the major toxicity. Gastrointestinal disturbances and cutaneous reactions, including pigmentation, can also happen. So pigmentation, hyperpigmentation can occur with different anti-cancer agents. One of the example is the hydroxyurea. So hydroxyurea is also important for your exam. Next coming is the microtubule damaging agents. There are two groups of the microtubule damaging agents. One is Vinca alkaloids, another is the taxanes. These two are also important. Different MCQs, different short notes also come from this. So Vinca alkaloids, these are mitotic inhibitors, bind to microtubular protein tubulin. So microtubule tubulin, they mainly act with this, prevent its polymerization and assembly of the microtubules. You know the assembly of the microtubules is important for carrying out of the DNA synthesis. So ultimately they causes disruption of the mitotic spindle and interfere with cytoskeletal function. So the Vinca alkaloids prevents polymerization and assembly of the microtubules, and the taxanes, the mechanism of action is just opposite. They causes more polymerization. So ultimately that will be a disorganized polymerization. So Vinca alkaloids prevent polymerization of the and assembly of the microtubules, and taxanes causes more disorganized polymerization of these microtubules. So example is paclitaxel and docetaxel. And another is the etramastine. So first coming to the vincristine. So there are three Vinca alkaloids. One is vincristine, another is vinblastine, another is the vinorelbine. So these are important. So vincristine is a rapidly acting drug, very useful for inducing remission in childhood ALL. Now one of the important treatment for this acute lymphocytic leukemia in children, but is not good for maintenance therapy. That is, it is used initially and then for maintenance therapy other agents are used. Other indications are the AML, Hodgkin's disease, Wilms tumor. Wilms tumor occurs in the kidney. Ewing sarcoma, it is another bone sarcoma, neuroblastoma and carcinoma lung. Prominent adverse effects are peripheral neuropathy. So vincristine prominent adverse effect is the peripheral neuropathy. So this is important. Apart from this, there occurs alopecia, ataxia, nerve palsy, autonomic dysfunction, syndrome of inappropriate ADS secretion and seizures. Bone marrow depression is minimal. So vincristine, you have to remember two. One is prominent adverse effect is the peripheral neuropathy. Next one is it can cause SIADH. So the questions of the MCQ, there are different agents that can cause syndrome of inappropriate ADH secretion, SIADH. So one of the example is the vincristine. Vincristine causes SIADH. So they are neurotoxic, remember. So they causes peripheral neuropathy. Next coming the vinblastine. Vinblastine, you can see the adverse drug reaction is the bone marrow depression. So here peripheral, no, it is not neurotoxic, but it is hematotoxic again. So the adverse effect profile is separate, while neurotoxic alopecia are less marked than with vincristine. Again, it is used in Hodgkin's, Kaposi sarcoma, non-Hodgkin lymphoma, breast cancer, testicular cancer, etc. Again, SIADH can occur. It can cause local tissue necrosis if extravasation occurs during IV infusion. So with vinblastine there occurs bone marrow depression. So this is hematotoxic. Next is vinorelbine. Here vinorelbine also causes neutropenia, which is a dose limiting toxicity. Thrombocytopenia, neurotoxicity are less marked. It is a newer agent. They causes metaphase arrest, and it can use mainly now in different types of the non-small cell lung carcinoma, and also used in advanced breast and ovarian cancer. So the Vinca alkaloids, you have to remember how these Vinca alkaloids act. They prevent polymerization and assembly of the microtubules. There are three agents: vincristine, vinblastine, and vinorelbine. Vincristine main adverse effect is the peripheral neuropathy, also causes SIADH. Vinblastine main adverse effect is the bone marrow depression. SIADH also happens. Vinorelbine mainly causes the neutropenia. Thrombocytopenia, neurotoxicity are less marked. Okay. Next, coming to the taxanes. So taxanes, the mechanism of action just opposite of this Vinca alkaloids. So taxanes, it is a complex diterpene taxane obtained from the bark of the western yew tree. So from the tree bark, these are collected and synthesized, exert cytotoxic action by a novel mechanism. This taxanes is also important for you. It binds to beta tubulin and enhances its polymerization. So Vinca alkaloids blocks the polymerization, but this taxanes enhances the polymerization. A mechanism opposite to that of the Vinca alkaloids, the microtubules are stabilized and their depolymerization is prevented. So basically this is a cycle of depolymerization and polymerization, but since there is more polymerization, the depolymerization is prevented, the stability results in inhibition of the normal dynamic reorganization of the microtubule network. This reorganization of the microtubule network is important for continuation of the DNA synthesis, newer DNA synthesis, newer cell growth. So ultimately that is essential for interface and mitotic functions. So this is the mechanism of actions of the taxanes. Within the taxanes there are paclitaxel. Paclitaxel is an important. They have ultimately causes abnormal arrays or bundles of the microtubules are produced throughout the cell cycle. So there are more polymerization. So there are more different, there are bundles of the microtubules are formed. These are disorganized microtubules. Indications, they are used in metastatic ovarian and breast carcinoma after failure of the first line chemotherapy and relapse. They are efficacious in advanced cases of the head and neck cancer, small cell lung cancer, esophageal adenocarcinoma, urinary and hormone refractory prostate cancer, age-related Kaposi sarcoma. So these are the different neoplasia where this paclitaxel can be used. Again, the adverse effect important. The major toxicity is the reversible myelosuppression, mainly granulocytopenia. That is, the granulocytes are mainly targeted. And stocking and glove neuropathy. Stocking and glove, that is only in the glove area and the stocking area, there occurs neuropathy. So important, reversible myelosuppression, that is when it is stopped, the myelosuppression will be reversed. So reversible myelosuppression and stocking and glove neuropathy are the main adverse effect of the paclitaxel. Paclitaxel is the most important agent under the taxanes. So taxanes mainly acts by increasing the polymerization of the microtubule proteins. So there will be more microtubules, disorganized microtubules. Ultimately, there will be no reorganization of this microtubular protein, and ultimately the cell's growth does not occur. Cell growth arrest occurs in the interface and the metaphase. Apart from this, nausea, chest pain, arthralgia, myalgia, mucositis and edema can also occur. Next is topoisomerase 2 inhibitor. Example is the etoposide. Etoposide is a semi-synthetic derivative of the podophylotoxins, which is a plant glycoside. It is not a mitotic inhibitor, but they arrest cells in the G2 phase. So already we have seen many agents that acts in the S phase. Now if you are asked that name one G2 phase specific anti-cancer drug, example is the etoposide. Etoposide is a topoisomerase 2 inhibitor. They cause the DNA breaks by affecting the DNA topoisomerase 2 functions. Already in the biochemistry, you know this DNA topoisomerase is again another agent that is required for the DNA replication. While the cleaving of the double-stranded DNA is not interfered, the subsequent resealing of the strand is prevented. Again, these are the different steps, and these steps are basically prevented in the tumor cells. Indications: it is used in testicular tumor, lung cancer, Hodgkin's lymphoma, carcinoma, bladder and stomach. Alopecia, leukopenia and gastrointestinal disturbances are the main toxicity. So you can see from these different agents that alopecia is more or less similar adverse effect of different anti-cancer drugs. So if you were asked that name some agents that can cause alopecia, alopecia means more hair fall. So you can example of these different anti-cancer drugs. So alopecia, leukopenia and gastrointestinal disturbances. Next, coming to the campotecan analogs. These campotecan analogs are the topoisomerase 1 inhibitor. You can revise your biochemistry that there are topoisomerase 2 and topoisomerase 1. There are 2 topoisomerases are there that are required for the DNA replication. So topoisomerase 2 inhibitor is the etoposide and topoisomerase 1 inhibitor is the campotecan analogs. Example is the topotecan and irinotecan. So they are anti-tumor principles obtained from a Chinese tree. They act in a manner similar to the etoposide but interact with the DNA topoisomerase 1 instead of 2. Binding ultimately causes strand breaks in the DNA. DNA strand breakage occurs but not its resealing after its strand has untwisted. So resealing is not interfered but strand breaks occurs. Damage DNA during replication, act in the S-phase and arrest cell cycle at the G2 phase. So topotecan is used in the metastatic carcinoma of the ovarian small cell lung cancer. Major toxicity is again bone marrow depression, especially neutropenia. Other adverse effects are pain, abdomen, vomiting, anorexia and diarrhea. Irinotecan is again another agent that is used in similar different types of the metastatic advanced colorectal carcinoma. Dose limiting toxicity is diarrhea. So very much diarrhea occurs with irinotecan also. So you can also see that diarrhea is also adverse effect of some 2 or 3 anti-cancer drugs. You have to note down of this that what are the adverse effects. Name some drugs that can cause diarrhea. So these are the examples. So neutropenia, thrombocytopenia, hemorrhage, body ache, weakness, etc. can happen, but the dose limiting toxicity is diarrhea. Dose limiting toxicity is the most important thing. That is, we have to limit the dose. We cannot increase the dose even if the increased dose is needed. So in different agents, when you will encounter the dose limiting toxicity is this, you have to note down this and you have to remember for the different drugs. Okay, this is important. Next, coming to the different types of the antibiotics that is also used. First, coming to the anthracyclines. Anthracyclines are doxorubicin and daunorubicin. They enter themselves into DNA and cause DNA break. They activate topoisomerase 2 and cause break in DNA strands. Again, the DNA strand breakage occurs, generates excess free radicals and damage to DNA. Important thing about this that you have to remember that they are known to damage the cardiac cells. So they have cardiotoxicity. This is very important for your exams also. So name the drugs that can cause cardiotoxicity. Example is daunorubicin and doxorubicin or anthracyclines. They cause cardiotoxicity. So apart from this, bone marrow depression, alopecia, stomatitis, vomiting, local tissue damage, etc. can also happen. Indication is breast, ovary, lung, prostate. Example, daunorubicin also used in ALL and AML. So within this daunorubicin and doxorubicin, you have to remember that they can cause cardiotoxicity. Remember, cardiotoxicity in the whole anti-cancer drugs only caused by the anthracyclines like doxorubicin and daunorubicin. Next, coming to the dactomycin or actinomycin D. It is a very potent antineoplastic drug, highly efficacious, used in Wilms tumor and childhood rhabdomyosarcoma, methotrexate resistant choriocarcinoma, Ewing sarcoma, metastatic testicular cancer. Adverse effects are vomiting, stomatitis, alopecia, discoloration of the skin, etc. Epirubicin, mainly used in breast carcinoma, more or less similar, and here is also cardiotoxicity is seen. So more or less all this can cause cardiotoxicity, anthracyclines. Next, coming to the mitomycin C. This is again a highly toxic drug used in resistant cancers of the stomach, cervix, colon, rectum, breast, etc. Superficial bladder tumors are treated by intravesical instillation of the mitomycin C. So if you are asked that you know about any route of intravesical injection, so intravesical instillation of the mitomycin C. So intravesical route within the urinary bladder, mitomycin C is given in case of the bladder tumors, bladder carcinoma. It is transferred intracellularly to a form which acts as alkylating agent and cross-links DNA. It also generates free radicals, ultimately destroys the DNA, more or less similar. Bone marrow depression, GIT, the adverse effects can also happen. Mitoxantrone, again, more or less similar, details is not required. Another important thing is the bleomycin. Bleomycin, important, it is indicated in testicular tumors, squamous cell carcinoma of the skin, oral cavity, head and neck carcinoma, esophagus, Hodgkin's lymphoma. Bleomycin is another agent that can cause pulmonary fibrosis. So lung fibrosis or pulmonary fibrosis can be caused by the busulfan and bleomycin. These are important for your example. So pulmonary fibrosis can occur by the bleomycin. Apart from this, mucocutaneous toxicity can also occur, but myelosuppression is very less. Basically, it chelates the copper or iron, produces superoxide ions, and intercalates between DNA strands, ultimately cause chain scission and inhibits repair. So bleomycin causes the pulmonary fibrosis and mucocutaneous toxicity. This is important. Next is L-asparaginase. L-asparaginase is leukemia cells. It has been seen that they are deficient in this L-asparagine synthase enzyme, and this is an important enzyme for their metabolism. So it degrades, L-asparaginase degrades L-asparagine to L-aspartic acid, depriving the leukemic cells of an essential metabolite. It is used in acute leukemic leukemia, acute lymphocytic leukemia, ALL. Many of the adverse effects more or less similar. It produces effects due to defective protein synthesis. It is antigenic and recipients may develop allergic reactions. So one important thing about the L-asparaginase is it is very much antigenic. So anaphylaxis, even death from the anaphylaxis can also happen with the L-asparaginase. Just remember this. Then coming to the differentiating agent. So basically they act at the differentiation. Example is tretinoin, arsenic trioxide, histone deacetylase inhibitor like vorinostat. So tretinoin, mainly it is a all-trans retinoic acid. It is a form of vitamin A. It is used in acute promyelocytic leukemia. Arsenic trioxide, again it is used in similar acute promyelocytic leukemia. Vorinostat is used in cutaneous T-cell lymphoma. Okay. So basically they induce the differentiation in the tumor cell lines. So that's why these are known as the differentiating agents. Then coming to the targeted drugs, so that they target a specific enzymes or specific areas, like tyrosine protein kinase inhibitors like imatinib mesylate. You know this imatinib mesylate inhibits the specific tyrosine protein kinase labeled BCR-ABL tyrosine kinase used in chronic myeloid leukemia, CML. So CML, the main treatment is the imatinib mesylate that blocks the tyrosine kinase. Indication is again CML, adverse effect abdominal pain, vomiting, fluid retention, etc. These are the different agents, name is required for which are used as targeted drugs, like epidermal growth factor receptor inhibitors like jeftinib and erlotinib, angiogenesis inhibitors like bevacizumab and sunitinib, proteasome inhibitors like bortezomib, monoclonal antibodies like rituximab, trastuzumab, bevacizumab, alemtuzumab, cetuximab, ozogamicin, gemtuzumab, tocilizumab, etc. So already in the immunosuppressants, you have read about the different monoclonal antibodies. So these monoclonal antibodies are basically target specific. They causes toxicity to the normal cells very less. That's why these are known as the targeted therapy. These are the newer agents but very much costly. So the names are important. So name some examples of the targeted drugs or name some examples of the monoclonal antibodies that are used in the cancer chemotherapy. So these are the examples. Of this, the proteasome inhibitor bortezomib is very important. So there are some natural products that are also used in cancer chemotherapy, like glucocorticoids is an important agent. They act by binding to a specific physiological receptor. Already we know they have effects and suppress mitosis. Use the cytotoxic agents in the treatment of the acute leukemia and malignant lymphoma in children and adults. So there are numerous indications of the glucocorticoids, and these glucocorticoids are also used as part of the regimen for different cancer chemotherapy. And different hormonal agents are also used. Like glucocorticoids, also already we have seen, also is in control of the malignancy chemotherapy associated complications. So when we are using the different agents for the treatment of the cancer, there are different complications also happen, and this can be curbed by giving the glucocorticoids like hypercalcemia, hemolysis, bleeding due to thrombocytopenia, retinoic acid syndrome, increased intracranial tension, mediastinal edema due to radiotherapy. These all can be used glucocorticoids. Afford symptomatic relief by antipyretic and mood elevating effects. Potentiate the antiemetic action of the ondansetron and metoclopramide. Okay. So already you have read in the endocrines that estrogen and selective estrogen receptor modulator. So estrogens can be used in carcinoma prostate. Selective estrogen receptor modulator, very important, tamoxifen. Selective estrogen receptor down regulators like fulvestrant and aromatase inhibitor like letrozole. These are important as endocrine drugs as well as the antineoplastic drugs. So the above three classes of the drugs are the anchor of the adjuvant and palliative therapy of the carcinoma breast, primary and secondary prevention of the breast cancer. So if you are given want examples of some endocrine drugs that can be used in the treatment of the cancer, so these are the examples. So tamoxifen, fulvestrant, letrozole, anastrozole, etc. Anti-androgens, these are also examples like flutamide and bicalutamide. In the androgen class already you have read. These antagonize the androgen actions. So these are used in the prostate carcinoma. So prostate carcinoma, flutamide, bicalutamide, anti-androgens are used because they increase androgen levels by anti-androgen actions in the pituitary. 5-alpha reductase inhibitors like finasteride and dutasteride. Already you have seen that these are used in the treatment of the benign prostatic hypertrophy. So these are also used. Have palliative effect in advanced carcinoma prostate. So what are the treatments of the carcinoma prostate? This is also important. So in carcinoma prostate, we have to use the anti-androgens. So anti-androgens, we know the flutamide and bicalutamide. So these can be used, and 5-alpha reductase inhibitor like finasteride can also be used. So they have palliative effect in advanced carcinoma prostate, and however it is occasionally used. So apart from this, GnRH agonist. So gonadotropin releasing hormone agonist can also be used in combination with anti-androgens on ACRMs in carcinoma breast and prostate. Progestins are used in metastatic carcinoma breast. Just remember the names, that these are the hormonal agents that can be used as cancer chemotherapy. So thank you. So this is all about the cancer chemotherapy. In the first class, you have read about the principles of the cancer chemotherapy. That is important. And the second class, during the class, I have already given the important points. So there are some agents that can come as short notes, and there are some adverse effects or some indications that is important for your Viva or for your MCQ or for your short notes. So thank you. Any question?
This is a part from the identification chapter. Identification, under it comes many things. Among them, one is bones. Bones से ठीक है identification की करे है. कैसे identify करेंगे bones से कि क्या हो, किसका bone है और कैसे इसका बारे में पता लगाते हैं. ठीक है. So first we should know about the anatomy. So anatomy, as you can see here, ilium, ischium, pubis, sacrum. Okay, these are the main things. So pelvic bones comprises of 4 pelvic bones: sacrum, coccyx, and 2 sets of hip bone. Hip bone है क्या से? Innominate. Hip bone is also known as innominate bone. It comprises of ilium, ischium, and pubis. And now we will know about the specific joints. Joints से क्या से? 4 pelvic joints. One is pubic symphysis joint. Another is sacroiliac joint. Two set of sacroiliac joint, and one is sacrococcygeal joint. Okay. This is basic applied anatomy we will be using here. This is acetabular fossa, femoral head, and what? Sacrum. What is this? Vertebra, lumbar. Then comes sacral. Okay. So we have learned about the applied anatomy. Now comes how we apply it and why we apply it. So the bone I have given it to you is innominate bone. So which part is which you can identify. Which part is the ilium, which part is pubis, which is ischium. Okay. And that joining of the three bones, that is triradiate cartilage in the acetabular fossa. Triradiate cartilage. Okay. These bones, it is fused. Next comprises of how will you answer in the exam. So the question will come, what is this? Identify the given specimen to you and draw the medico-legal inference from it. So you will, what will you write? This is a dried and this is a human articulated femur, dried and devoid of soft tissue. Okay, that would be the answer. For if in case it was femur, then it is a human femur, dried and devoid of soft tissue. Sacrum, if it is a sacrum, dried and devoid of soft tissue, human sacrum. Okay, like that you will answer. It is a human articulated pelvis, dried and devoid of soft tissue. And while you are facing the examiner, you should hold it in your anatomical position. In anatomy also, and as well as in answering in viva during your forensic exam. So what medico-legal opinions can we form from it? Those are all the same for all bones. That is sex, age, injury, stains, disease, deformity, times incident, manner of death. It will be similar for all bones. Okay. Now coming about the estimation of sex from bones. As I previously told you that from the entire skeleton, 100% chances are there we can identify the sex from whole skeleton. If only pelvis is available, there are 95% chances that we can identify the sex. Means 5% chances are there that we may not be able to identify the sex. Now coming to skull is 90% and long bones is 80%. Okay, that is from our famous anthropologist, according to our famous anthropologist Krogman. He said all these things. Entire skeleton 100%, pelvis and skull 98%, pelvis 95%, skull 90% and long bones 80%. So this will be asked in exam, practical viva exam, it will be asked. So you should at least know this part. Okay. Now coming to the main thing of pelvis, that is, this is the best bone to identify the sex of the subject. Okay. If the bone is given, we can, from pelvis, the estimation of the sex is the best bone. This is the best bone to identify the sex. Means in the entire whole skeleton. Okay. If this single bone is given, we can identify the sex. There are 95% chances we can identify from this bone. Okay. This is the male, that is female part. Okay. Guess what it is? Which one is this one? Male or female? Male, female. Okay. Correct. What is this? Guess. This one is female. Okay. I will tell you why. This one is male. So you look at this chart and try to differentiate. I am holding it. So first of all, it is given that it's massive, erect and muscular markings are more prominent. Okay. Whereas in the female, it is less massive, less erect and smoother and stands lower. So as you can see, the ilium, it is like in males, it is erect, the ilium part, erect. Okay. Whereas in female, you can see it is more like a flattened ball, like a saucer. Okay. That's why it's not erect. Whereas in male, this is comparatively straighter, erect. Okay. So that was our first difference. General shape is deep funnel shape, and whereas in female it will be flat bowl shape. Okay, funnel shape means like this, males, and or for females it will be flat. Okay, why is this differences? Because the pelvis in females are God made it that way to accommodate the baby. Okay, for delivery purposes, the female pelvis has to be more spacious so that the baby can come out. Otherwise, it will get stuck. That's why all these features will be there that I will be discussing right now. There are about 29 differentiating features, but few features will be similar in both male as well as in female. Means there can be features which we cannot say from those features that it is male or female. That's why we will take all the features, 29 features, and then we'll see which majority of the features false, and then we'll differentiate whether it is male or female. So, coming to the ileum, as I told you, it is more erect and all. Curve of the iliac crest reaches higher level, more prominent in male. You see, as I told you before, it is more prominent and reaches higher level, more erect. Then coming about the preauricular sulcus. This one is important. What is preauricular sulcus? So you have the hip bone with you, right? You have, where is the preauricular sulcus? That's the question. You know, show me the greater sciatic notch. Anybody knows where is greater sciatic notch? Yes, that's the greater sciatic notch. Above it, there is preauricular sulcus. It may not be prominent in your cases. Hold this time. See, it is a female pelvis. I will pass it on, and here it is. Okay. So the preauricular sulcus is more prominent in females. It is more deep. Not this one. They see here. Okay. Have a look. This is greater sciatic notch, and there is the preauricular sulcus. It is more prominent in females. Those the bones you are holding there are mostly of male bones. So it may not be there. It may not be so prominent. So not prominent, narrow and shallow in male. It may not be there also. But in females, it will be prominent, deep and broad, as I showed to you. Okay. Why it is more prominent, deep and broad in female? Why is it so? Because there is a ligament insertion which holds the uterus. Okay. That is why it forms a deep sulcus. Okay. That is why. Acetabulum, as we have previously in our previous class of long bones, it will be more. This part. This diameter will be 52 millimeter in males, whereas 46 millimeter in females. Other features. Obturator foramen. This part. Okay. This part is large oval with base upwards in males, whereas in females it will be triangular shape, small triangular with apex forward. So this is a male one. Okay, you can see it is more oval, like an egg. Egg is oval shaped, like that. You are holding, I guess, how is it? Obturator foramen. Everybody has a specimen with you. So what is the shape of it? Oval or triangular? See, this is a female one. It is triangular. Okay. Those are mostly males. Okay. Now coming to the greater sciatic notch. This is the most important parameter, greater sciatic notch. Greater sciatic notch, as you can see in females, this is a female pelvis. Okay, this is more wide. See, the both ends are more wide, whereas in male it is, where is it, less wider. Okay, the depth is more in males and width is more in females. Okay, that is the most important. So in exam, if the examiner asks you that tell me just one parameter from which we can distinguish whether it is male or female, you will answer greater sciatic notch index. Okay, the male width is more in female, whereas depth is more in males. Okay, clear? From that we can come to the sciatic notch index. As I told you, width by depth into 100. Width is numerator. If numerator is greater, then what will happen? In females it will be more, as width is more in females. So we have arrived with the value 166 in females in adults, whereas in males it is 145. So as I told you, it is the best bone to determine the sex. Okay, why so best bone? Because in other bones, until puberty, means puberty for a, we can say that we can estimate the sex. But this is the only bone we in childhood also we can identify, in fetus also we can identify from this bone whether male or female inside the uterus also. Okay, that is why. So like that, you can see the sciatic notch index for fetus is 4 to 5, that is less in males, whereas in female 5 to 6. Okay, that is for fetus, and the above value is for adults. There also you can identify. Okay, for fetus, children, adults, everybody we can identify from this bone, but other bones we might not. So that makes it the best bone for sex determination. Now coming to the ischial spines. Show me the ischial spines. Mostly it's broken, but here it is. Okay. Here and here, both. So, ischial spines. Ischial spines and ischial tuberosity. So, in males it will be inverted, okay, and female it will be everted. Inverted, everted. Fine. Why it's inverted in males and why it is everted in females? Females, because we have to deliver the baby. If it is inverted, then the baby will get stuck. So God made it this way, so that we can accommodate the baby. Take out the baby, sorry. Now coming to the next index or features is the kylotic line. Chilotic line, kylotic line, whatever you may say. It is. Okay. From here it begins, okay. From here till the tuberosity over here. I will show you in that one. It will be easier for you. It starts from here, ileum, okay. You see that there is an eminence like thing, that is the kylotic line, and here up till here, and there it extends to this tuberosity, not the whole part. It will end above the eminence, okay, just here. So this is the, where is it? This is the sacral part up till here, and this is the pubic part up till here, okay. It has sacral part and pubic part, kylotic line. From this we will form an index also. So as we can see, the kylotic line index. So as I told you, sacral part and pelvis part. So pelvis part is more in female. Pelvic part is more in female in kylotic line, because we have to accommodate the baby. It should be more. and sacral part is more in males. Okay. So as the index states, sacral part by pelvic part. If the numerator is more, that is in males, it will be more. Okay, as I told you. If it is sacral part, if the sacral part is less, then it will be female, less than 100. Okay. Body of pubis. This small thing over here, that's body of pubis. Okay, this small thing. What does it state there? Narrow and triangular in females, whereas males narrow and triangular, and broad, square or quadrangular in females. So this is a female pelvis. You can see it is square shaped or rectangular, or okay, whereas in males it is more short of triangular. Okay. Then the superior ramus of pubis, this part, it will appear as a continuation. This is male. See, there is no thinning or something, whereas in female it is somewhat thin. Okay, not like a single bone. It is thinner over here, but here it will see it's like a continuate bone. Means the whole thing is more or less same size. There is narrowing in females, constricted or narrowed appearance. Now coming to ischiopubic rami. So it is rough, heavier, more everted. Male, you see how rough it is, heavier and more everted. Whereas there it is smoother, lighter and less everted. See. Okay. Female, male, heavy. From this we form ischiopubic index. Now this part is important. Ischiopubic index are also known as Washburn index. So examiner will ask you what is Washburn index. So you must know the numerator and the denominator. Numerator is pubic length by ischial length. Simple, pubis is up and ischium is down. Numerator, denominator. So how will you measure it? Measurement is taken from the acetobulbar fossa center. Okay. You will have a vernier caliper. You will put the caliper here. Other end here. You will measure. Okay. And here. Okay. This is pubis. This is ischium. Here and here. Here and here. Okay. So in females it will be more because the pubic length is more. Okay. Numerator is pubis. So obviously females it will be more. 91 to 115, whereas male 73 to 94. So almost all we have 10 more parameters. Symphysis pubis, higher, narrower and lower. These are the two tubercles. Okay. In males it will be, this is female. Okay. In males it will be closer, whereas in females this tubercle it will be wider, means apart. That's one feature. Then as you know the shape and all, the pelvis in males is what shape? Heart shape. Male is heart shape. Why? You see, it comes here and then goes. Whereas in female, sorry, this one is the male one. Okay. Male, it is heart shape. And this is the female. It is more elliptical or spacious. Okay. What is given there? Elliptical, spacious or circular. Why so? Because to accommodate the baby. Okay. If something is protruding out, this is heart shaped male. If this thing is protruding out, means it is constricting the space. The head of the baby will not pass through. If this sacral promontory is so prominent. See, the sacral promontory is more prominent. This is for males. That is why in males it is heart shaped, whereas in female it is elliptical, circular or spacious. So all the parameters in female, the inlet, outlet, brim and all, it will be more wider and more capacious. Okay, those features you have to write in your exam also. Means while you get the specimen, then you have to write the features. What features you have got. So these 29 features I have mentioned, out of which whatever you find relevant, you will write down, so that in conclusion you can come that it is male or female in exam also, practical exam. Now coming to the subpubic angle, that is also one major differentiating factor. Subpubic angle is this one. Okay, this is 70 to 75 in males and wider in females. Okay, this is almost U shape, this is V shape. Very important. After greater sciatic notch, subpubic angle is the most important factor. Then comes the preauricular sulcus and all. Now comes the sacroiliac joint surface. Okay. Sacrum, ilium, this joint surface that you are holding, that abnormal ridge like thing. So look at it. Just give me one second. See this part. How does it look? Large and angulation is less sharp in male. Means more obtuse. Whereas in female it will be small, angulation is sharp and almost L-shaped, acute in female. So that also I guess is what? Male or female? Male. More angle. Obtuse. Right? This is okay, fine. Another thing is coccyx. Coccyx is more movable in females. That's also part for reproduction, to accommodate the baby. Now comes what? So you can take this lecture home. Okay, means you can take this presentation home. You can at home also, you can compare those numbers with these parameters. Okay, 1, 2, 3, 4, so that you can revise before exam and before that also, to recapitulate everything. What is this? Subpubic angle. Okay, 70 to 75 in males, females it will be more. Okay, what is this? Ilium, more erect in males, less in females. Pubic tubercle, wider in females. Okay, then what? Ischial tuberosity, more, it is heavier, more prominent in males, less prominent in females. Heart shaped in males, circular in females. Okay, ischial spines. Okay, inverted. Then what? Almost all done here. Next. Greater sciatic notch, width more in females. Okay, depth more in males. Fine. Ischial spines. So ischial spines also, if it is inverted, then it will be in males it will be less, the distance between two ischial spines. And if it is inverted, then females it will be more, distance will gradually be more. Obviously be more. kylotic line, okay, sacral part, pelvic part. Okay, fine. Sacral part is more in males, pelvic part more in female. Forms an index. What is it called? Index. Okay. This is the articulating surface, sacroiliac. Okay. L-shaped in, acute in females. Acute in females, obtuse in males, larger. So that in large, because the sacrum part, that sacroiliac joint, it joins this sacrum. When I talk about sacrum, I will make you understand that fact, why it is so. What else? Nothing. Sacrum part, while I will discuss, I will tell you why that part is more and what is the significance of it. Okay. Triangular in, pubis triangular in male. This circular. This is oval shaped, and quadrangular or square shaped in females. Now coming to the sacrum. As we have answered, it is an articulated pelvis. So sacrum is a part of it, coccyx is a part of it. To learn about sacrum, very small topic, very small topic. Sacrum, important parameter means applied anatomy. We'll talk about anatomy is, this is ala. What is this? Sacral promontory, okay. This is important thing. These are S1, S2, S3, S4, S5. Coccyx is not there. These are foramens, okay, and these are transverse lines. First vertebra, second vertebra ends, third vertebra, fourth vertebra, okay. Now coming to the fusion. For age, we will see the fusion. There, we have to see whether these lines, transverse lines are fused or not, okay. From that we come to the age. And from this breadth and all, we will come to the sex. Okay, I will just show you how. So, if it only this sacrum is given, you will state same as other bones. Human sacrum, divided and divided of soft tissue. Sex differences in human sacrum. Size and shape, longer and narrower, okay. Longer and narrower. Female shorter and wider. Curvature, more evenly distributed. Means it will be, there will not be much difference. Whereas in females, the curvature is not seen in upper half. Means it will be straight, upper two vertebrae, and then abruptly it will go down. Straight and then go down. Okay, so that's about the curvature. Sacral promontory, well marked, more prominent, okay, whereas less marked. That's why it is heart shape in males. Sacral promontory is more. Body of first sacral vertebrae is larger. This is more, whereas in female it will be less comparatively. Sacroiliac articulation. This is what I was talking about. Suppose these two, this will attach here, right? Sacroiliac articulation. So, as we know, sacral part is more in males. Obviously, so this articulating part will be more in males only. So, sacroiliac articulation is large, extends 2.5 to 3 vertebrae. So if you, where it ends, that ridges and all, that the articulating surface ends, if you count first vertebrae, second vertebrae, and almost third vertebrae. So it will be more in males. The golden rule is, you should remember that it extends to 2.5 vertebrae most. At most it will be up to 2.5 in female. It will be more in males. अगर 2.5 vertebrae मतलब 2.5 vertebrae तक ये articulating surface extend हो रहा है तो वो female है, उससे ज़्यादा नहीं होगा. It will end there only. But in males, it extends from 2.5 to 3 vertebrae. Means it's more articulating surface. From that we form an index, sacral index, anterior superior breadth of sacrum by anterior length. Breadth, whole breadth by length. I'll show you. Female से बेशी है. Anterior superior breadth of sacrum by length. Okay. This is body of first vertebrae. Clear? Another two indexes. Alar index, width of wing by breadth of first sacral vertebra. Width of wing by breadth of first sacral vertebrae. Okay. Forms an index called as alar index. Males it will be 65, female it will be 80. Okay. Width of wing by breadth of first sacral. Next, coprovasal index. Breadth of first sacral vertebrae. Breadth of first sacral vertebrae by anterior superior breadth of the sacrum. These things one have to by heart. Okay. How to measure I told you. Fine. There will be index. Age estimation. Sex part is over. Now how will we determine the age? So age can be determined by two ways. One is fusion parameters. कौन कोথায় epiphysis fuse होচ্ছে? Fusion. Second is by pubic symphysis articulating surface. This part. Only from this part we can also estimate the age. Mostly in the third decade, 30 years, around 30 years, best thing from which we can determine the age. So, age by epiphyseal fusion. Epiphyseal fusion, iliac crest, what are there? Iliac crest, okay, ischial tuberosity and acetabulum. This triradiate cartilage. As I told you, what is triradiate cartilage? Yes. Where the 3 points meet. So, in iliac crest, appearance is 17 years and fusion is 20 years. In these bones, fusion has occurred. These bones are of old person. So, in X-ray, there will be a separate class for X-rays. In that class, we will talk about age estimation more detailedly. There I will show you the X-rays from where you can see almost all distinguish the fusion and non-fusion part. Here it's all fused. Appearance and fusion. In females, the appearance is earlier and fusion is almost similar. Ischial tuberosity, 16 to 18 years appearance and fusion is 16 to 7, whereas females 14 to 16 and fusion is 14 to 15. Means it is earlier in females, fusion. Acetabulum, that is disappearance of triradiate cartilage. So in X-ray what happens is at 13 years, approximately in 13 years we will be identifying we can see the triradiate cartilage, that 3 division parts will be there, okay, and that will disappear in by 15 to 16 years, whereas in a female it will be disappearing by 14 years. Means you won't be able to see the triradiated cartilage, it will disappear. In X-rays it is more clear. In the next class we will take it, next class after this is over. So this is for as per Gallstone chart, Okay, Goldstone conducted this study on Bengali population and he found these parameters. Okay, Goldstone, name is important, Goldstone. Because Goldstone chart is, what do you call, accepted in High Court. Calcutta High Court, it accepts it, this chart. So it's important. Other charts are there for other population. Punjabis will have their own chart. South, they will have their own chart. North, they will have their own chart. For East means Bengal, it is our chart. This population. Issue pubic ramus unites at 7 to 8 years. So by the changes of pubic symphysis, means this articulating surface, okay. Best is 3rd to 5th decade to estimate the age. So what are the parameters? Todd was an anthropologist. He performed study. Many people, many scientists have made a study on this part also, age estimation by pubic symphysis, but for making the class easier, we will take only one scientist, anthropologist, will follow his classification, Todd's classification. Okay. So he divided it 20 years, 20 to 25 years, 25 to 30 years range, 35 to 40 years, 45 to 50 and above 50. So thing is that till 20 years, this part will be smooth. Up till 20 years, this part will be smooth. If you can feel it by your finger, it will come in this range. Okay, I will tell you what are the differences. In 20 to 25 years, this part will be more ridged, irregular, and billowing will be there. Ridged means ubad khabad hobe, ठीक है, ubad khabad hobe, और rough surface er moton lagbe, ठीक है, it will be rough, ridged, and billowing. Billowing means ridged, like a terrain. After 25 to 30 years, this billowing will start disappearing. Means the ridges will start to disappear, whereas the anterior and posterior margins will be more prominent. Okay, the ridges will start to disappear, means ubad khabar ta kume jabe. In a gist, what will happen is earlier it will be smooth, then it will be ridged, and gradually it will become smooth. Okay, by erosion and all. So in 25 to 30 years, as I told you, anterior and posterior margin will be more prominent. Granular prominent anterior, okay. From 35 to 40 years, articular surface becomes smooth. Articular surface will become smooth and oval with raised upper and lower margins. Means upper and lower margin will be more raised. Earlier it was anterior, posterior. Now it is upper and lower margin. Now, at the age of 40 to 50, articular surface encircled with beaded rims or bony erosion. So, this part inside, it will be appearing as small islands. If you see the world map, or where Japan will appear like small islands. Okay, in globe or map, Japan will appear like small chain of islands. Those are beads. Malar moton, putir mala. We wear necklace and all, small pearl necklace, something like that. So articulating surface encircles with beaded rims. The surface will added like beaded rims. Means malar moton mone hobe, ঠিক আছে? Then after 50 years, there will be bone erosion. It will break. Okay, bones become well marked and breaking of the margins. Margins will be broken. Mostly you will be finding broken margins. Okay, if you feel it, somewhere here or there, it will be broken. Mostly broken, it will be there. Okay, this thing, if you take the PPT, you have to memorize. While exam, you have to again reproduce it. So now will come age estimation by sacrum. Sacrum is very easy. Bodies of sacral vertebrae unite with one another. They unite at margins but not at the center. At 20 years, they will be almost united. But what happens is, in this sacrum, everything is united, but in certain cases, the central part, the transverse line, central part gap will be there. Central part. Side, suppose I am transverse line, okay. This part may not unite, but this part will unite. Okay. This part may not unite. In old people also. At 25 years, sacrum is one bone. The whole thing will be means ossified. Okay. It will become one bone at 25 years and remains unossified up to central area may remain unossified. As I told you, side may be fusion might happen, but central may not. Till 50 years, it may remain unossified. So, from sacrum, age estimation is not very accurate. Okay, for a gist. So, you have only two parameters. You can say whether it is 20 years or 25 years. Okay, and the thing is that the fusion occurs below upwards, from down to up. Down to up. Whereas in sternum, anybody remembers how the fusion occurs? Up to down and down to up. Revise it. Okay? Confusing. Appearance is one order and disappearance is in the reverse order. In the what you call sternum. Union occurs from below upwards, as I told you. Now comes time since death. Very easy thing. I think I have told you in the previous class. So this is 6 months, heavy, greasy, bad odor, hard to touch. Same thing applies here also. 6 months to 1 year, soft tissue remnants will be there, ligament insertion may be there. 1 to 5 years, you can find by microradiology. We will find the vacuoles and all, see through the microscope, electron microscope, and find the vacuoles. Fallacy is there that in apes, higher apes will resemble the humans. So that's only one area where we cannot identify. In 50 to 100 years, N content is nitrogen content. Nitrogen content in the bone is 4 to 4.5% up till 100 years. Then it will gradually decrease in bones. Nitrogen content decreases in bone. Okay. Whereas in teeth, nitrogen content increases. Okay. 200 years, up till 200 years, UV fluorescence. I have showed you. I just drew on paper. I guess you were there on the previous class. Long bone. Cut section, UV fluorescence, UV lamp you will apply and see whether there is a radiation of blue color is appearing on the bone or not. If it is more blue, then it is fresh, and if it is less blue, and gradually decreases as the bone ages. Okay. Then after 350 years, nitrogen content is less than 2.5%. And beyond that, we will go for carbon dating, fossils. So while in exam, if somebody asks you, how will you estimate the age, don't start with carbon dating. Okay, it is useless parameter for us. For anthropologist or studying dinosaur, it is okay. But this is the last one. Okay. Cause of death could be from the bones. Bullet wound may be there, burns could be there, deep cuts could be there, chopped wound. Okay. Diatoms, what is diatoms? Diatoms. Diatoms is single celled algae found in water, unicellular algae. Okay. So these things, what happens is, what is the significance of diatoms? Suppose a person, police brings you a body claiming that the subject was found floating in the water. Died floating in the water. Body has been floating in the water. Now the police may ask you the cause of death and manner of death. That is the most important thing for police. Other identification part they can locally identify by face and all. But cause of death and manner of death, that they will be asking. So from diatoms, we can say find the cause of death. So whether the person has drowned in the water or somebody has killed him and put him in the water. Difference is there, no? मार के फेंक दे या डूब के मर गया, ठीक है? तो diatoms में what happens is, if the person is drowning, the person will try to struggle. Okay, बचाओ बचाओ बचाओ, कोई बचाओ, nobody will be there. So he will be drinking water. So diatoms enter with water inside. So in the body, in the blood, we may find diatoms. In the bone also, we may find diatoms inside. Okay, so that that helps us whether the death was antemortem or postmortem. Antemortem माने डूब के मर गया, postmortem माने मार के फेंक दिया पानी में, ठीक है? So that is where the diatoms role play. There are fallacy that will be in postgraduate level. Up till here it is okay. Disease of bone, as previously discussed, fracture, poison, heavy metals and all. Okay, fracture, clear na? So